how do we intentionally rebuild a sense of community?
Every single person around the world can create a movement.
Please welcome Executive Vice President of AtlanticLIVE, Candace Montgomery.
Hello and good morning, everyone. And good morning. And welcome to our 2025 Health Summit. Thank you all for joining us. Innovation, technological advances, and policy changes have disrupted the healthcare landscape as we know it. While challenges to healthcare access, curing complex diseases, and scaling innovation persist, so do areas of opportunity for emerging technologies and revolutionary modern discoveries. Today, we will be joined by medical experts, scientists, healthcare leaders, and advocates to celebrate the recent breakthroughs that are redefining medical practices and interrogate how we navigate the complexities and challenges presented by this pivotal moment in healthcare. Before we get started, I want to thank our underwriter, Eli Lilly and Company, for their support of the Atlantic's journalism today. A few housekeeping notes. Please silence your cell phones, but don't put them away. We want you to be a part of the conversation online. When posting on social, please use hashtag Atlantic Health. Now, let's get started.
Here to discuss advancing early disease detection, please welcome Stephen Hahn, CEO of Harbinger Health, with Daniel Engber, Senior Editor at The Atlantic.
Hello, everyone. Dr. Hahn, thank you so much for joining us.
David, thank you for having me. Really good to be here today.
A one-person panel discussion is my favorite form of panel discussion. We can actually get somewhere.
We certainly will, no question about it.
So I want to ask you about Harbinger Health and the focus on early stage cancer detection. I thought maybe we could start with really the basics here. If you could describe, what's the landscape of early cancer detection now? What does Harbinger Health bring to that, and what is the landscape you'd like to see form in the near future?
Yeah, for sure. So as you probably know now, in the United States, there are 5 cancers for which there are approved screening tests. And the whole purpose of those those tests is to actually help diagnose cancers early. Because the one thing worse than being told you have cancer is being told you have late-stage cancer. So this is all about trying to find cancers early. And the 5 screening tests we have, in fact, have shown to actually improve survival because they do help to find cancers early. And the American Cancer Society has estimated that the significant proportion of the improvement in cancer-specific mortality, so reducing death from cancer, is from screening modalities. But that's only 5 of the cancers, and only, I think it's 15 to 20% of cancers are diagnosed with screening cancer tests. And so we need to do better. About 2/3 of people in the United States and more around the world, particularly in the global south, are diagnosed with late-stage cancers, which of course are incurable. And it's probably touched everyone in our lives, this fact. So what the landscape is now is that what's emerging is a technology, and I laugh all the time with folks that work at Harbinger Health, because when I was an oncology fellow, if someone had come in the room and said, we can draw a tube of blood and find circulating DNA from cancer in your blood, they would have been laughed out of the room. And now, of course, we know that that's the case, that cancers shed DNA in the blood and that we can detect it. And the question is, can we detect early stage cancer? And that's one of the big challenges, is that many of these tests find late stage cancers. And finding late stage cancers from a blood test is good, it's just not where we need to be in terms of early stage. The other parts of it, so that's the part of performance. We need to be able to diagnose early stage cancers to cure more people. We also need to know that when a test is positive, it's real, that it's a true positive, something that doctors refer to as positive predictive value, so that when you look, you'll find it. And then the final part of that is, where should the doctor look when you draw a tube of blood and they say, we think you have a cancer? So that could be from, toes to head, right? And so there's a part of the test that we call at Harbinger tissue of origin, which tells the doctor, we think this might be a breast cancer or a lung cancer or colon cancer. You should look here. And of course, there are pathways that doctors can use to diagnose those. So there's certainly this performance part, which is absolutely critical. And then there's the clinical utility part, which is what does the doctor do with the information? And you can't leave the doctor blind. And so I don't know how you all feel about this, but nowadays you can go and get a whole body MRI, usually not covered by insurance. And I have a problem with that because in a person who has a very low risk of cancer, and the risk of cancer in an asymptomatic average risk group is about 1.5%, you're more likely to find a false positive than a true positive with a test like that, which means you're more likely to need a biopsy, et cetera, which could harm you rather than help you. So these tests have to have tissue of origin and have to have a relatively low false positive rate. And then the other point of this is access. So we're great at developing innovative new therapies that cost millions of dollars, and what we don't actually have is enough access for people who need it the most. And post-pandemic, there's a loss of trust in public health, in big companies, in doctors, in big medicine, et cetera. And what we have to do is make this accessible to everyone. So it has to be near point of care, and it has to be inexpensive. So that's the future that I'd like to see for cancer screening. Yes, you can go to your doctor, get an inexpensive test, rule out a cancer, or say, I'm a little worried, we need to look, where should I look? And then find an early stage cancer. That's where we need to head.
I'm glad you brought up trust. I want to come back to that. But in terms of the basics of what Harbinger's test does, how many cancers are you testing for? You mentioned the importance of having more, true positives than false positives. What can you say about the actual specifics of what you're testing for and how effective and useful it is?
Yes, so we just completed an 8,000 participant study looking at our test and our biological markers, the DNA that we're looking at in the blood. It's based upon something called DNA methylation, which is a fundamental event that occurs in a cancer cell. When a normal cell decides to become a cancer cell, this pathway, this DNA methylation gets turned on. And so we find it at the earliest stages of cancer. And by the way, we licensed this technology from Harvard and from MIT, so it's a local homegrown set of biological markers. The power in that is that it starts very early in cancer development. So we have seen, we think, very good performance for early stage sensitivity, and we have found ways to really push this positive predictive value, so reduce the false positives. And then, of course, using data science and AI and ML techniques, we've been able to develop a way to say this is the tissue of origin that the doctor needs to look at. So we are well on our way to producing a test that allows us to do the things that I just talked about.
So, I'm sorry, how many cancers is it?
Between 20 and 25 cancers.
20 and 25.
About 80 to 85% of the cancers that are diagnosed in the United States.
Okay, so you have the data showing, about how well you're doing. I mean, it seems like with all these cancer screening tools, the big question is this saving lives? At what point will we know whether your multi-cancer detection tool, or there are many that are coming out that are using blood tests to test for multiple cancers at once, when will we know how those as a class are performing?
Yeah, well, we're talking years, not decades, before that will occur. And this is something that I feel fairly passionate about and is informed by my time at the FDA during COVID, and that is, do we have to wait the 50 years it took us to reduce cardiovascular mortality from treating cholesterol, diabetes, and hypertension? When we identified those risk factors, again, a Massachusetts-based, or maybe it was Connecticut, I don't know, Framingham study that identified those factors. Where? Okay, sorry, that was bad. I should know my geography and history better, but thank you. But the point there is that it took us 50 years to see a 50% reduction in cardiovascular mortality. That's not okay. So the strict answer is we need to see a reduction in cancer-specific mortality. We need to cure more people of cancer. Can we accelerate that? And can we accelerate innovation and look at intermediate or surrogate markers, what we use for the accelerated approval pathways at the FDA? I would argue that we absolutely have to do that people are dying. So let's take a cancer like pancreatic cancer. Can someone tell me what percentage of pancreatic cancer patients are diagnosed with stage 1 or 2 disease? The only stages where it's curable. Oh, that hand went up. Yeah, okay, good. It's small, right, it's 5 to 10%. So, and that's usually found, right, because you see it incidentally on a scan or something like that, certainly not because of symptoms. So could you imagine a study where you diagnose 50% of pancreatic cancer patients with early stage disease? That's a surrogate marker where I think most of us would argue that's a good thing. You're probably saving lives. You don't have to wait X number of time for cancer-specific mortality. And you can take that disease by disease by disease. So I think we can accelerate it, and we're going to try to do that. We're in discussions now with the FDA about our product. We're going to go forward with our pivotal trial coming in the next year.
So what proportion of the cancers that your test can identify are early stage?
So that will need to be tested prospectively, but our sensitivity is, I think, substantial, close to 50% for early stage disease.
For across cancer types?
Yeah, across the cancer types, that's right. And of course, it matters which cancer, right? I mean, that actually is a very important. So imagine a world where 50% sensitivity exists for pancreatic cancer. That's a pretty big deal. You might want a higher percentage of early stage cancers for breast, colorectal, lung, where you have existing screening products.
I believe that 50%, that number is higher than what's been reported for some competitors. I know you don't want to talk too specifically about competitors, but I am curious. This is a crowded space. There are a lot of companies have multi-cancer liquid biopsies coming out. What sets yours apart from all the others?
So I think a couple things. One is the biological basis. So does everyone remember the argument of a couple years ago about the Biogen drug for Alzheimer's and how do you identify people, et cetera? One of the issues there is, do you have the way to identify a disease early enough to actually make a difference when you intervene? And is that way of identifying the disease biologically related to what causes that disease? And that's the advantage of the Harbinger test, is the fact that this biomarker set is related mechanistically to the development of cancer. And that's different than, I have stage 3 or 4 cancer, I drew some blood, I found circulating DNA, and I'm associating that with cancer. Because then when you move to earlier stages where there's less of it in the blood, it becomes more problematic to pick it up and also more problematic to say that it is really associated with that cancer. So I think that's the one underlying issue here for us. The other is we have a very unique testing approach, which is a multi-tier approach. So think about a woman who gets a mammogram for breast cancer. So she gets a screening mammogram. Do we tell a woman who has an abnormal mammogram she has breast cancer? God, I hope not, because you're not supposed to. Very high sensitivity, picks up a lot of stuff, but very low specificity. So what we tell a woman is come back in a couple months, we'll repeat it, or get a spot compression view or an ultrasound, something that helps decrease the false positives, increase the specificity. So we have a proprietary approach for a very similar testing approach. Tier 1, which is a low-cost, rule-out test, if you will. If it's negative, you can be pretty sure it's negative. If it's positive, we're not telling someone they have cancer. Go to the second-tier test, which is a more detailed test that gives a cancer yes-no answer and also gives this tissue of origin. So trying to fit a cancer screening paradigm into an approach that's a single test is very hard to do, and certainly with a blood test that's multi-cancer. So those are the big things that distinguish Harbinger Health, I think, from the competition. And the other part I'll just throw out is that I think this is applicable to across the cancer care continuum. So not just screening for cancer, but monitoring cancer and also finding out different ways to treat cancer.
I propose there's at least one other thing that separates Harbinger Health from these other companies, and that is you. You're the former FDA commissioner at a singular time in American history. Talk about, based on that experience, what's next for, you're going to be seeking FDA approval at a time when I would say there is tumult at the FDA. What challenges do you see in going through that process, given what's happening in Washington?
Yeah, well, first of all, I'll say we have a terrific, I'm not personally allowed to be involved in those discussions with the FDA, so just so you know, our team does it, I don't do it. But we have a terrific review team at the FDA. So assuming our terrific review team stays at the FDA, I think that would be good for Harbinger Health. It is a challenging time. As you probably know, FDA is the largest of the operational divisions within Health and Human Services. It grew by a substantial amount in terms of people. And I don't think anyone who has gone before the FDA or who is at the FDA would argue with the point that the process needs to be improved to advance innovation. And that's one of the great things about being FDA is that everybody there is dedicated to public health, pretty much. And the mission is to promote and protect the public health of the United States citizenry. And so what we saw is dramatic, 19% force reduction. I have a lot of confidence in the leadership right now at the FDA that they have a handle on what this is about, that there is an attempt to reduce duplication within the agency, not touch the review process, and do the absolute best we can to actually enhance that. Because what I'd personally like to see are more resources on the science and the review process side and less on the administrative side. If that can be accomplished, and we'll see. I think the jury's out on that one. That would be great for all of us. But it is an uncertain time, and you can see that in the markets for a variety of reasons. But at the end of the day, if we really are going to achieve our goal of helping people to protect their public health, their own personal health, but also promote, I think, making people health and you know, have a longer lifespan, then that's what we've got to do. I think this ties incredibly well to the cancer diagnostic side of things, because this issue of preemptive medicine, cancer is an easy one to talk about because it's the second leading cause of death. It's what we all fear, et cetera, et cetera. The success we've had in cardiovascular disease is another example. But we've got Alzheimer's. We've got Parkinson's. We've got metabolic diseases. We have, I think, a significant, maybe it's not an epidemic, but a significant outbreak of allergy and autoimmune diseases that we hadn't seen when I started practicing medicine. Why is that? What's the underlying biology? Can we identify it early? And can we intervene early? And we have that opportunity. And I'd love to see the agency go in that direction. How do we create the pathways to actually allow us to do this in 5 years as opposed to 50 years?
So it seems to me that there are a couple things going on at the FDA right now. One is maybe creating efficiencies. Maybe it was overstaffed. Maybe the process was slower than it needed to be for various reasons. And I suppose it's possible that by reducing staff, you could speed things up, although I could also see it going the other way. But we're also seeing some other, just in reporting, alarming signs of political interference. Peter Marks's departure, the reports that approval for the Novavax vaccine was held up by a political appointee. This is something you dealt with publicly yourself. The president tweeted at you to stop playing games and release the damn vaccines. So you've been in that seat. You've had the political pressure on you. Is it going to be, tell us how you dealt with that. That seems very difficult. And then how you see the current leadership in place at the FDA dealing with what seems like even more intense political pressure.
Yeah, my first thing I'll say is it's Washington, D.C. So the FDA has never, ever in its history been without pressure on it, no matter what direction you're talking about. So yes, it was extraordinary and extreme, and you're right. It was a difficult period of time. That I will certainly admit to you. It's going to sound really simple, but I'm just going to say it because it's actually true, and you can talk to the folks who worked with me when I was at FDA. It's very straightforward. The American people are the FDA's patient. That's the bottom line, and it needs to be approached as the doctor of the American people, number one. Number two, our North Star, always focus on it. That was getting a vaccine out as quickly and as safely as possible. And then, you know, it's what your mom told you when you went to school. Tell the truth and do the right thing. Really isn't that hard. It's really not that hard. So tell the truth about what you know, what you don't know, and then, you know, execute in a way that you're doing the right thing for the American people. Will you always get it right? No. Will you always have pressure from the outside? You have to ignore the externalities because otherwise you can't do your job. And I think being a doctor very much prepared me for that in those situations, because ultimately it was about doing the right thing for the patient, which was the American people. And think about the vaccines. 45,000, 44,000 participant studies for the vaccines, mRNA. The vaccines were developed in record time, 11 months after the identification of the viral sequence and the emergency use authorization. And that happened during a time of great tumult, during a presidential election, et cetera. I'm really proud of the agency and what it did. But we hear afterward a lot, because 44,000 participant studies are only going to tell you so much about efficacy and safety. And then we had the greatest human experiment of real-world evidence afterward, where 10+ billion people received the vaccines, and we learned about all the side effects and the efficacy. Did we know that when they were authorized? No, we did not know that. Is that a mistake? No, I don't think it's a mistake. It's the way studies are done, and we have to recognize the fact that we're going to find things that we didn't find in a more limited group of people. And so I know I'm wandering from your original topic. I'm glad to go back. But my point is, when we talk about things like cancer diagnostics, when we talk about things like identifying Parkinson's early, we are going to be in a situation where we identify things, we do interventions, and we're not going to know everything. And what the American people, I believe, want to know is that you're doing the best you can, you have all the information to make a decision, but that you'll revise that decision when more information comes. That's what a doctor would do if you were sick and didn't have all the information. And I truly believe that no matter where we live, what our socioeconomic background is, what our gender, race, ethnicity is, that at the end of the day, we all want the same thing, which is to be healthy and well. And I think that we can get there. And I think the FDA can do it. And my advice to the current group is focus on helping keep people well and healthy. North Star.
That's great advice from a doctor. You mentioned trust, and I think you were circling the trust issue just now. I mean, this is the core of what we're talking about. I remember that was discussed at great length, trust in public health in the fall of 2020, exactly when you were dealing with these issues. If you push out the vaccines too early, people will lose trust. You had Kamala Harris in a vice presidential debate casting doubt on the safety of the vaccines, and how things flipped over the next 18 months is quite interesting. What is happening now at HHS is all being phrased in terms of how to restore trust in public health. Do you think that's what's happening?
No, I don't think that's happening right now. I mean, that's an objective answer to what's happening right now. But we're also in a time of turmoil. And I think, to me, it gets back to this issue of trust, in that who doesn't trust us? And I mean us as in people who went to college, people with advanced degrees, people who run companies, et cetera, people in academia. And it really breaks down around socioeconomic lines. To some extent, surveys have shown that it breaks down around racial and ethnicity, but really it's socioeconomic that it breaks down in terms of trust. It isn't this group of people. And so what I say to you is that it is likely that the people in this room are losing trust. I'm going to guess that. I'm going to hypothesize that. God knows I shouldn't speak for you, but I'm going to throw that out there. My guess is that the people in other socioeconomic groups outside of this room, this is the way they're going to rebuild trust with them. That's my guess. And I don't know that, but this disruption, because of where they've been, how they feel, what you see in surveys is real. And those are our countrymen, those people out there.
I'm sorry, the disruption will rebuild trust?
I think the fact that what we're seeing is an incredible disruption of the status quo, that's what many people want to see, because they were they felt harmed by the status quo. I'm not a politician, I'm not an economist, I'm just saying, and I do live in Texas, so we can take that as it may. But there's a different feeling in other parts of the country than in Cambridge and in San Francisco.
Tell me about
We need to build trust with those folks too.
Tell me about the regulatory path you're taking with Harbinger and how that relates to what you see out there in Washington.
So I think it relates to trust. So you probably know our test and others is in a category called laboratory developed tests, or LDTs. And there's recently a rule put forward by the FDA asserting regulatory authority over laboratory developed tests. And you could argue that a cancer screening test is a pretty high-risk test because what you're doing is ultimately, hopefully, leading to a diagnosis of cancer. That was struck down by a federal court. So now we're a little bit back to where we were before, which is that people can develop laboratory-developed tests without going to the FDA. Now, that being said, I think when you have high-risk tests like these cancer tests, it's actually very important to get FDA approval because folks need to be able to trust that someone has had some oversight over this. Now, that's a pretty unpopular point of view, but we plan to go through the FDA process to get approval of our test because we feel that that stamp of approval is so important for providers, patients, and insurers. You don't have to do that as current law stands or current practice stands, but our plan is to actually go down that regulatory path.
So can you give a sense of what the timeline would be for that?
Yeah, we're talking the next couple of years, hopefully shorter. A lot depends on the conduct of our trial, how long it takes, the endpoints we use, et cetera. But we're really trying to shorten the pathway to ultimate approval, and that, of course, is a negotiation with the FDA.
And when are the full results from your trial going to be public?
Probably a couple of years.
Okay.
Yeah.
All right. Well, we're winding down to the end here. So I just want to say, Dr. Hahn, thank you so much for joining us. It's quite an honor to get to talk to you.
Daniel, thank you very much. It's great talking to everybody here. I hope you have a great day. Thanks.
And now for a conversation on the big story, COVID 5 years later, please welcome Daniel Ingber, Senior Editor at The Atlantic, Catherine J. Wu, Staff Writer at The Atlantic, with Sarah Laskow, Senior Editor at The Atlantic.
Hi, guys. We're really excited to be here with you. I know you just got to hang out with Dan, but
This is a far more comfortable seat, I just want to say.
Okay, well, I know I'm jealous. So we're going to talk a little bit about our experience reporting on COVID for the past 5 years, which I feel like is a long time and also not such a long time. And so I thought basically we would spend a little bit of time talking about the beginning, the middle, and the now. So Katie and Dan and I didn't actually work together at the beginning of the pandemic. So I was going to ask them, when you were first as a journalist, learning about this new virus and getting a sense that this was going to be a story that you might cover, what was the moment where you really kind of understood how big an event this would be and how big a part of your life as a journalist it would be going forward?
So I feel like it happened in kind of two phases for me. I think when the entirety of Wuhan shut down, I was like, oh, this is going to get so much worse, so much more quickly. That was January of 2020. And the next month, I, for some reason, found myself traveling to New York. And I think that's when the news broke that Italy was very rapidly shutting down. And I just remember thinking, I really need to get home. And just thinking the rest of this year, the rest of this decade could look really different. But I didn't even appreciate how much at the time. And I think it was just a few weeks after that I started working entirely from home.
Yeah, it's funny. It's much easier for me to remember the moment just before realizing than the moment of realization. For me, that was a meeting with, I was writing for Slate at the time, and I had a meeting with other Slate journalists, and we were talking about, science journalists, and we were talking about, this new virus. And I remember saying, I think we are underplaying the effects this might have on the primaries, and that seemed like the undercovered story. So I was kind of like assuming that the virus would spread to the United States and spread widely here, but then I couldn't, my brain wasn't even able to make the connection of what that actually means, and so I was focused on sort of a secondary story. Well, that could affect the political process. Of course it did, but right, it was there was a more important story. If it really were such that it was affecting the primaries, it would also be affecting public health in a fundamental way. So I think that was like the last possible second before understanding this is something we're going to be covering for years.
Yeah. And I don't know, I find myself struggling to remember even how little we knew at the time. Do you remember what were the questions you were asking at the very beginning? Right, it's can we even remember?
Yeah, I mean, I think they were, I don't know, they were all the super basic questions everyone else had. How does this spread? Am I worried about the frozen food I'm getting from the grocery store? Probably not, but I don't know. And I remember there were weeks of coverage where people were how effective is it to wash my hands? And I felt pretty good about hand washing at the time, to be clear, but it was just so interesting that it was every time there's a crisis, it's always back to basics with the questions that everyone's asking.
Yeah. What about you, Dan?
Yeah, I mean, just human-to-human transmission was the big one.
Right.
And also that experience of looking at these preprints from China was just sort of an interesting, it was a new form of science reporting that I wasn't used to. It was so specific, and it was very odd.
Yeah. I feel at the time there was a big debate about how much should we just report on preprints, right? How, and do you think that that's stuck around? Has our relationship with science that hasn't gone through peer review and things fundamentally changed at all in the way we cover it?
I think yes. I mean, I'll see stories all the time based on preprints. That has persisted. Maybe pulled back a little bit. There was a stretch there where, a preprint study that had not been through peer review was just immediately covered by all major outlets, almost without acknowledgement of the difference between the status of that research and the status of research that, we used to cover. I think it's pulled back. Katie, tell me if you agree. But I think it's pulled back somewhat, but you still see that. And, there's just more awareness of these preprint servers where all that research appears. And there's just, it's in the toolbox of the media in a way, if that makes sense. It's something you can do. I think before the pandemic, there was a sense that, you're not allowed. You would have to come up with some really strong affirmative argument for covering unpublished research. Now, that's less the case.
Yeah, no, I agree with that. I mean, even just a couple weeks ago, I feel there was a COVID-related preprint that was covered as a single study story by multiple outlets. And yeah, it's definitely stuck around. And I still feel even when people are writing bigger picture studies, people are just chiller about linking directly to a preprint and not laboriously saying and additionally there may be some additional evidence in a study that has been submitted to a preprint server but not yet published in a peer-reviewed scientific journal and vetted by multiple experts. Which is still worth saying, but people were so skittish about that before, and it's mostly gone away.
Yeah, I think that's an interesting question though. I know you were just talking about trust in science, right, Dan? I wonder how you guys think about the relationship between the audience's understanding of what you're telling them about non-peer reviewed research versus peer reviewed research. Peer review exists for a reason. Does it affect how people understand what we're telling them if we report more on non-peer reviewed research? does that help with trust, or does it like diminish trust?
Yeah, no, it's an interesting question. I feel like, and just to, I guess, bring this all the way back around to like something that really changed for me when COVID started in terms of reporting. I felt like I just got so much more worried and careful about portraying everything as incremental, and this is our understanding up to right now, which like a lot of preprint studies are going to fit in with that bigger picture. That is just how it goes. And even like fully peer-reviewed stuff published in a scientific journal, that doesn't mean it's set in stone forever. And so I feel like just making sure that like through line of uncertainty and like this could be upended with new data possibly at any second, especially at the height of COVID when everything was changing every second. I felt like it hopefully engendered more trust, just to trust that the public could handle that nuance. Like, this is what we get now, and either the situation may change or the understanding may change or both simultaneously, and what you read a month from now may feel like it contradicts what I'm telling you right now, but that's kind of just how it goes.
Yeah. Well, and I think that is one of the big questions that came out of like COVID, how public health like treated COVID, how the media treated COVID, is like this question about whether people in public health, people in the media were treating like Americans broadly as like people who could process a lot of complicated information quickly, or were trying to like downplay things or simplify it like for the sake of messaging in some way. And I don't know, just like, I think one thing that I've happened to have talked to people a lot recently about is like the way that like we talked about masks at the beginning, both in like the media or in public health, like the very, very beginning where people were like, oh, like masks maybe don't help that much, but it was really just because there weren't enough PPE, and so people like downplayed potentially like the protective value of masks. But I think maybe like a more interesting like way to like talk about that was like once COVID vaccines were available and like there was a lot of still unknowns about like how they worked. Like I was looking back at one of the first stories we did together, Katie, and it was about dose delay, like should we still have so little supply of vaccines, like should people wait to get a second dose? Do you really need a second dose? What's the like right amount of time to wait for the second dose? And so much of the actual science about that was determined by circumstance. Like there was like a real push to just get the vaccines out. And so, like the initial trials for like how like the gap between the two doses were in some ways like determined by just the need to do it fast. And so I wonder like, this is like a big question to ask, but like, how do you guys think like the public communication about vaccines succeeded or failed, like, and the ways in which we tried to, like, people in public health, and then we as the media talking to people about public health, like, tried to balance between giving information and like offering clarity?
Yeah, that's a great question. I think what just while listening to both of you talk, what it was in my mind was just this idea of like, oh wow, it was a really multi-layered crisis of authority with talking about the science here for the public health researchers and the public health officials and the policymakers and the science journalists, right? Because you're at a moment of maximal uncertainty and also maximal urgency. So your uncertain understanding of the science needs to be applied right away to discrete decision making, or in our case, actionable information for our readers. I mean, even at a trivial level, I just remember one story I worked on with Katie about when you go to get your COVID shot and your flu shot, should you get it in each arm or the same arm, right? It's actually a question many people, my friends and family members, asked me. They wanted to know, what should I do? And so I thought, oh, this would be a great topic for a story. But my recollection is the science was pretty uncertain. And so it was like, even at that micro level, we were confronted with, there are millions of people going to get their flu shot and COVID shot. They want an answer to this question, and they're just all you can do is say, well, it's complicated. Here's what we know. You might want to do this, but maybe not, and it might be wrong. So, I mean, that just stands in for I was going to say what a disaster was. I don't think it was a disaster, but what a challenge it was. And I think that, you know, it's possible that the after effects of that crisis are still being felt now.
Yeah, it's funny to think about that example because, like, really probably the, like, TLDR of that piece was, like, it doesn't really matter. But, like, for so many other difficult communication snarls, the stakes were crazy high, right? Like, and I mean, to stay on vaccines, like, probably the biggest fumble there was how much of the initial messaging around COVID vaccines was, like, 90% effective against infection, and that was taken to mean in perpetuity. Like, I get this shot and, like, I rip off my mask, I walk out into the sunlight, and, like, life is good again. And that turned out to not be the case. I mean, it was challenging because, like, when they were doing those trials, they could only measure up until a certain time. They were only measuring certain things, and they weren't following people, like, through the variants that arose for, like, months at a time. They didn't have that long to wait. Like, it was understandable why that was so much of the messaging early on, but it became really quickly clear that, like, this was not a permanent shield. And I think a lot of people in the public felt betrayed by that initial messaging. And then all of a sudden, like, it was like, okay, so you did get your vaccine, you do have to keep your mask on, you do still have to be careful, there may be more shots in your future. And that was rough. I think the whiplash of that made people disengage. I feel like that was a real communications inflection point in the pandemic that we never fully recovered from.
Yeah, like, and what effects have you seen in your reporting when you talk to people of, like, those kind of, not like miscommunications, but just like the limits of what we knew and, like, how, like, the kind of understanding of those limits got lost, like, sometimes in translation, I guess.
Yeah, I mean, I think as time wore on, it was both like, I'm not totally sure I can trust what I'm hearing because I've been a little burnt before. And also the messaging, I think, became relentless and exhausting at a certain point, like another shot or continue masking or like isolate for this many days, test this many times. People got really burnt out on it. And I think, like, I don't think I have the perfect solution to how all that could have gone better. I think the fatigue would have set in either way. I think the confusion would have set in either way because it was inescapable. But even now, I feel like people struggle to find the middle ground with anything from, like, H5N1 bird flu to, like, what's happening right now with measles. We're sort of stuck in this binary mode of total panic or, like, total disengagement, and it's really hard to find the safe middle ground.
I do think that, like, one thing we found in, like, right, like, when we're thinking about stories and stories we want to do and, like, thinking about who the audience might be for them, it's like we do now see, like, a pretty big divide in a way we didn't during, like, the height of COVID in terms of, like, what questions do people seem to want to, like, have a burning desire to have answered, and, like, what groups have those questions. Like, we've talked a lot about that, like, in our measles coverage, because, like, we do talk to people who have, like, questions about, like, oh, I'm an 80s baby, like, should I get a measles booster if I, like, didn't get the course of vaccination that's recommended now? But the people who tend to have those questions are a smaller group than people who had questions about COVID and, like, a particular type of person. And I do think that's just, like, a really different public health information environment than we were in during COVID, and it's also been shaped by COVID, and we've seen that over and over again. Like, I think we've seen that, like, in our Mpox coverage, in the bird flu coverage, in the measles coverage. I mean, maybe you guys can think of more examples of how it's shown up. I don't know. But the thing that I was going to ask you was sort of, like, when we're, like, thinking about questions like this, like, how do you think about your role as a journalist and, like, a communicator in those moments? Like, we work for a publication where we make arguments and we do try and, like, you know, help people think through things, but also have a point of view. Like, how do you navigate the like role of just giving people information and like giving people advice almost, or like, you know, advancing a message that you think is the right one?
Yeah, well, maybe it's just because I'm sitting on the couch now, but one thing that I feel like has been a through line that makes me uncomfortable is there's some aspect in COVID coverage and bird flu coverage and measles coverage, which is just telling people, answering the question, how scared should I be? How much anxiety should I feel? And I mean, that's not a good thing for a science journalist to be talking to, I think, really. Yeah. And yet, it's part of the job, right? Like, you want to give the facts. But that's where I think, you know, you hit that difficulty of, well, the facts may be uncertain. There's no, you know, I can't tell people how worried they should be. That's a personal decision, right? It has to do with your risk tolerance and your, you know, your health context and the health context of the people around you. So, yeah, I struggle with that because I like to gauge what would be a good thing to cover based on the conversations I have, you know, with the people around me. And often, you know, with bird flu, it comes down to like, how scared should I be today?
Right.
And that's not really like, we could just have like a, you know, like the New York Times election needle from like, don't worry about it to, you know, move into the bunker. Maybe that would solve the problem, but like that's just like an endless challenge, I think.
This is a great idea. Maybe we just need a dashboard on theatlantic.com with like different diseases and different needles that we can adjust for people. That would be a public service, maybe.
Yeah. This is the time to bring up the doomsday clock again, your favorite. Your question is a great one, and I think the way that I've tried to think about this is like, right, I totally agree with you. Like, I'm not telling people how to feel or even how to act. Like, I certainly don't set out to write a piece that's like, you must get revaccinated now. You must, like, take something off or put it on right now. But more, here's how to think about it, and, like, guiding people to, here are the 3 or 4 or 5 or 6 choices in front of you. Do what you will, but at least you have the information that I can provide for you in like a logical order. There's so much chaos right now. Can I at least tell you what feels pretty certain, what feels medium certain, what feels less certain, and like try and cut out the rest of the noise. That is how I'm hoping to like clarify instead of instruct, I guess.
Yeah. I do think in some ways that has become more and more challenging as like we have to think about like, right, kind of like how much are we gonna get into fights with like health information, misinformation that's like circulating, like how much, what is the worth of like, of trying to like, you know, like knock down like things that are, we see coming up and like saying like, okay, well like actually understand this in a different way, or if that's kind of like another way to just talk to ourselves instead of like a broad audience. I think like, I mean, we are now in like a really different moment. Like, I think in some ways, like the Trump administration is like the biggest development in the story of COVID in like 2 years, you know, like, and I think like, Dan, you've been thinking a lot about like the administration and how there's this group of people who were advocating for ideas about how to do COVID that during like the beginning of the pandemic were less in the mainstream of like how we actually dealt with it. And now those people have like been empowered in some ways. I wonder if you could just talk a little bit about how you're thinking about that group of like contrarian COVID thinkers who are now leading the country, and like what questions you have about what effect that's going to have on public health going forward.
Yeah, it does seem like the nominees and appointees for senior public health leadership positions, one criterion was, were you a COVID contrarian? Were you, going against the public health mainstream in 2020? And so we have Jay Bhattacharya running the NIH, who has kind of like made a persona out of being the fringe epidemiologist, the censored thinker who wanted to end lockdown sooner and reopen everything and strip away all the vaccine mandates. And Marty Macri at FDA same, right? So there is this sense that that people who have talked for years now in terms of almost seeking vengeance for the way that their perspective was suppressed and ignored, it's quite striking. They're in charge now. And so what does that mean? What does it mean for someone who was, a contrarian thinker on COVID in 2020 to have the reins of NIH or FDA in 2025? I mean, that remains to be seen. It's, how do you redress the wrongs that are, the perceived wrongs that are not relevant? Like, nothing is shut down now, so it's not like you can reopen the schools and you've solved the problem. So what do? You try to foster an environment of free speech at NIH. That's what Jay Bhattacharya is pursuing. But I think it's a sort of an interesting question of both of what are they going to do to address those lingering concerns, and also what happens the next time there's a big public health crisis? How much are we going to see kind of a hangover from the battles of 2020 in 2028 or 2029 when we have the next pandemic?
Sometime. Yeah. And then the last thing I wanted to ask, and then I think we have time to open up for questions, but like when we think about like what are the questions we still have about COVID, like as a scientific matter, like what do you guys think is left? Like, I think one just like interesting thing that's happened recently in the back and forth at NIH about like what will be cut, what's not cut, what gets reinstated, was that they cut a bunch of the long COVID research, but then it's like been reinstated for now. And I am like just curious what you're still watching, Katie, in terms of like questions that like you think are of public interest about like what COVID is even and how it affects us.
Yeah, I think long COVID for sure. I mean, not just because there are still a ton of people who got sick early on in the pandemic and are still sick now, but because as far as we can tell, people are still developing long COVID today. And so, why is that still happening? Are we expecting those rates to eventually go down? Is long COVID going to be with us forever? And if so, how are we going to support that? And I think that affects a ton of other ways, like how we approach COVID. Like the acute disease is still going to kill people, especially people with pre-existing health conditions. How is that going to affect like the way we approach vaccines? I think a lot of what we've been thinking about with the Trump administration is going to be their approach to vaccines. Are COVID vaccines still going to be around, or look how they do now? Are we still going to be told to get them every year? And if those protections are taken away, will the disease look fundamentally different? Like, does it look better now than it did 5 years ago because, we have vaccines as a matter of fact? And if that goes away, who knows? I still think we don't know what the disease is totally going to look like in, 5 years, 50 years, 100 years. So there's a lot to still pay attention to. Like 5 years is actually not that long at all.
I think that's maybe a good point to open it up for questions if people have questions. Yeah.
So I heard a story recently. Thank you. I heard a story recently that the head of the CDC at the time of the pandemic said that there may have been, among the public health leadership, too much of an orientation toward preventing death versus saving the economy and helping kids get back to school. And there was fact-based media that basically backed the public health side of things. And that led to, and then the data apparently is that neither one really mattered, right? The death rates were the same whether you were in Massachusetts or Florida, right? So, but what it led to was fewer people in Florida got vaccines because the trust broke down. So the question is, what role did media play in that, and what is media's role going forward related to that? Because you mentioned the contrarian nature of the current Trump administration. Look, I live in Massachusetts. I was doing what the public health leadership said, but the head of the CDC said it was a mistake not to entertain that debate more about should we be preventing life or should we be protecting the economy? And I don't know the answer, but we didn't have the debate, or the debate got shut down. And media played a role in that. And what is media's, if fact-based media played a role in that, what is media's responsibility, or what do you learn from that?
I think we've talked about this some among ourselves recently. Like, I don't know, I mean, I have lots of personal answers to your questions in some ways, but I think like if I were gonna rethink our coverage in some way, probably, I think like the clearest like year to me in which those questions, like the kind of like public health orthodoxy hung over the media coverage more than it maybe could have, was like 2021 after vaccines were available. Like, I think it's exactly in that moment that Katie was talking about, where like the kind of like way that the vaccines had been portrayed was like as like a kind of like open and shut case for like reopening society. Like, we'll get vaccines, like everything will be hunky-dory, and then like we'll move on with our lives. And when that became more complicated, like I think that was a moment where like the media didn't necessarily, like as a whole, I don't like talking about the media as a whole, but like including like, you know, like Atlantic coverage didn't necessarily catch up with that reality as fast as it could have. So I think in some ways it's just always just pushing ourselves to like, right, like ask what are the things that we're assuming, and like, are we talking to too many of the same people? I don't know, I think there's ways in which like you saw across the media, there did develop like different casts of characters who got quoted over and over again, like both like in the public health mainstream and like some of the guys that Dan was talking about, like also like there's like 5 people or something who like, I don't know, it's a little bit more than that, but like who got like quoted in the media again and again as like people having opposing viewpoints. And so I think some of it, which we talked about at the time too, is just like making sure that we're broadening the group of people we're talking to as much as possible to make sure that we are like understanding the full breadth of the debate. I don't know what you guys think.
Yeah, I think excuse me, I think one of the things that sort of happened from my view is there was kind of like a service journalism creep. So I was talking about this article about whether you should get 2 shots in your left arm or 1 shot in each arm. That's simple service journalism, health journalism, like telling people what to ask for at their doctor's office. But I think it started early in the pandemic. It spread into other forms. I remember early on in maybe February of 2020, there was a whole bunch of stories came out that, you know, when we didn't understand what the infection fatality rate from COVID was, and there were a whole bunch of stories that all parroted the same idea: it's no worse than the flu. And there was a real sense, I remember at the time, of, I mean, this wasn't reporters making this up, but there was like a message that was being pushed out from the public health world and from the doctors, if I can generalize, that was sort of, the principle was like, we don't want people to panic. Panic is going to be a real problem, and we all need to work together to prevent panic, right? And so that was just incorrect. Incorrect information was shared. It was not malicious. But it was sort of like a form. I think it ended up being a form of service journalism. It just wasn't clear what was being serviced or whose interests were really being served. And I think that's the danger. And that played out in multiple ways, especially in those early months where there was just like everyone wanted to be helping, right? And there was an idea that everyone needs to be, we need a society-wide response, so everyone needs to be pointed in the same direction. So it was almost like willful groupthink, because groupthink was understood to be the solution. Like maybe the group was thinking the wrong thing, but the group needed to be thinking something, or it was going to be total chaos. So it was kind of like a fear of chaos if there were too many views circulating. And, you know, I think there's probably some validity to that. You need to create like a unified response. But of course, it has great dangers associated with that if you're like willfully pushing a narrative simply for the sake of narrative, right? So yeah, I mean, I don't think that's a satisfying answer to your question, but I think the question is essentially an impossible one.
Cool. Well, thank you guys all so much for coming and for hanging out with us, and we hope you enjoy the rest of the day.
And now for a research spotlight on novel anesthetics for care in battlefield and disaster areas, please welcome Hale Fotoat, Senior Scientist at the Wyss Institute.
Oops, if I can, that's all. Hi everyone, it's a great pleasure to be here and to talk to you about our new work that we're doing at the Wyss Institute on discovering novel anesthetics. So what does a general anesthetic need to accomplish for you? So there are a few important conditions that have to be met. One is that they have to make you unconscious. They have to suppress all your pain, and they have to keep you immobile. They also have to be in a way that hopefully you don't remember things that happened during the surgery, and all of this has to be reversible. The problem with the state-of-the-art anesthetics currently is that they achieve all of this, but in achieving all of this, they also suppress other vital functions such as heart rate and breathing, and for that reason, they have to be given to you in a hospital setting where advanced machines have to be connected to you, or you need to be connected to them to stabilize all these vital functions. So for that reason, these are not suitable for battlefield or disaster areas where there's no access to hospitals. So this challenge was brought up by DARPA to develop anesthetics that could be used outside of a hospital setting, and that can be used to reduce injury-associated trauma and improve combat casualties. So at the Wyss Institute, we responded to that. And being at the Wyss Institute, we like to be inspired by nature. So we asked the question, is there any example in the nature that resembles this situation of general anesthesia? And the first thing that comes to mind is hibernation. So look at hibernating animals. How do they do this? So a hibernating animal is unconscious. They don't move, and they don't respond. There's highly suppressed response to sensory stimuli and pain. And they achieve all of this through highly suppressing their metabolism. And they do this really, really well. They don't need any machines. They do this all on their own. And this is all fully recoverable without any external interventions. It's all good. We're awake. We're eating our crackers. So how do they do that? So we were inspired by that, and actually we were at a very good point of looking at this question because we were just finishing up another DARPA program, DARPA Biostasis, the goal of which to find therapeutics that would induce a hypometabolic state, a state of really low metabolism, to preserve cells, molecules, and organisms. And for that, for obvious reasons, we were also looking and getting inspired by hibernating animals. And through a series of literature search and computational drug discovery, we identified some existing drugs that we predicted they would induce this super suppressed metabolic state. We tested these drugs using various platforms and various tissues and organisms, including whole organisms, which was frog babies like Xenopus tadpoles, and showed that treating them with these compounds highly suppressed their mobility, their metabolism, and their oxygen consumption. I'm going to go tell you a bit more about that in a bit. We also tested them in human cells, human organs and chip, as well as porcine hearts. In these cases, at the case of the porcine heart, they also reduced the metabolism, so this could have applications for organ preservation for transplantation. So this project had finished up at this point, and we then asked, can these compounds that we discovered, and sorry, I forgot to mention that some of these compounds, the pre-existing compounds, we also did additional medicinal chemistry on, some of which, for example, had opioid activity. We managed to remove the opioid activity and saw even better effect in suppressing metabolism in some of them. So we were very excited about these compounds, and during this program, we asked the question, can these biostasis compounds be used for general anesthesia? And for this purpose, our team at the Wyss made a collaboration with other groups at Harvard and MIT to look at this question at various levels and across multiple organisms. At the Wyss Institute, we are, as I mentioned, using Xenopus tadpoles for high-throughput behavioral screening. These are great models, easy to work with, very cheap, so we can screen drugs very quickly and inexpensively. We also work on drug prediction and target identification. Our collaborator at Harvard, other Harvard lab, Florian Ungert, is looking at the brain mechanism. So using larval zebrafish, they can look deep into the brain and quantify the activity of neurons, and they're working on that aspect. And then finally, our collaborators at MIT are going to test these biostasis compounds in their mouse model. They also are approaching this question of novel anesthetics from a different angle, which is identifying the minimal circuits in the brain that need to be activated to achieve anesthesia. I'm going to talk about that a little bit later. So going a little bit deeper into what we do when we play with Xenopus tadpoles and how we assess this question of general anesthesia, 3 of the main aspects of being in a condition of general anesthesia is immobility, unconsciousness, and lack of responsiveness to painful stimuli. And for these, we have behavioral assays that we can use. So for immobility, we have groups of tadpoles. These are little cute tadpoles that we have in petri dishes and treat them with the compounds. And 2 of the dishes are treated and 2 are untreated. And I assume that you can tell which ones are treated. So they really go to sleep, reduce the movement completely. And this is, of course, fully reversible. And this video is, by the way, sped up. They don't move that fast, but they're. And then the other setups that we have are these multi-well plates. We have a microscope, high-resolution microscope that can track individual tadpole movement. And it can also present various types of sensory stimuli as well as painful stimuli and look whether or not they're responsive to it. So the top video shows an untreated group of tadpoles. They're going to receive a tap like this on the dish. And if you've seen taps on an aquarium, you'll know that if this would generate a startle response. When the red light comes on is the moment where the tap happens, and you see that they generate the startle response. The bottom are, I think the video is running, yes. So these are the ones that were treated, and the responses to that is significantly suppressed in a reversible manner, and now we've shown that this is also true for pain stimuli. So these compounds we're very excited about. They're inducing this hypometabolic state and also achieving these other aspects that we need for general anesthesia. So as a next step, the Ungert lab is looking into the brain mechanism and also looking into the brain in the regions that are known to be processing painful stimuli and sensory stimuli to make sure that they're indeed suppressed and that it's not that the animal is not reacting because they just can't move, that they don't actually perceive these stimuli. So here you can actually embed the head of this little baby larval zebrafish in a gel. So the head is stabilized, so we can do brain imaging at a cellular resolution, but at the same time you can follow the tail movements and look at the behavior. So there are transgenic zebrafish that express indicators of activity in all of their cells, and you can look at every cell in the whole brain in the zebrafish. This is something you can't really do in mammalian systems. But the great thing is zebrafish are vertebrates, and their brains are very similar to mouse brains. There are all these regions that are homologous. Also, the major neurotransmitters are conserved, so whatever we find from these studies will be helpful for future studies in mice, which our collaborators will carry in MIT. The lab of Emery Brown, which is an expert in anesthesia, they're going to test our compounds next and look at various measurements like EEG, EMG, behavior in mice and compare them with state-of-the-art anesthetics and see how well they work there. And the other 2 labs at MIT are looking into looking at this from a different angle. Can we find minimal circuits that we can stimulate in the brain that would get us to general anesthesia state without affecting other regions that suppress heart rate and breathing and all the good stuff that we want to continue having? And they are using techniques called optogenetics and chemogenetics to specifically stimulate or silence brain regions that are important for these aspects. And they have found particular areas of the brain that they stimulate. So for example, the central amygdala, there are some neurons that have really highly pain suppressive properties. Here is a video of mice that have received the painful stimuli on their paw, so they're licking it, they don't like it. As soon as the laser light comes on, those specific neuronal populations, here laser on, get stimulated and the mouse stops generating this kind of pain response. So they're having really good results so far, and they're identifying now the molecular targets on these neurons that could be addressed with drugs. Another region of the brain is known to be important for arousal and consciousness. The other group at MIT are looking at other chemogenetic approaches to inhibit this region and looking at the animal behavior to see if they get a response. So to summarize now, in the next step, we are working on identifying targets from our model and from the mouse models and together with zebrafish model to validate the anesthetic properties of biostasis compounds, but also predict novel compounds that can be used to get safer and more efficient general anesthesia. So here I would like to thank our team at the Wyss Institute as well as our collaborators, and thank you for listening.
Here to discuss the path forward, policy impacts on healthcare and innovation, please welcome Kate Walsh, Secretary of Health and Human Services of the Commonwealth of Massachusetts, with Ross Anderson, staff writer at The Atlantic.
All right, Secretary Walsh, thanks for being with us this morning.
Thanks for having me.
Yeah, I want to start, a lot of us, if you care about biomedical research or health outcomes, have been sort of watching the first 90 days or so of this administration, the Trump administration, with kind of abject horror. But it's been hard to understand what's actually happening on the ground. And I figured Massachusetts, because there's so much biomedical research that happens here, is probably the closest place to where we could actually find an impact crater for all these policies. And so to start out, give me a sense, what's the worst thing that's happened here for the first 90 days?
I think the worst thing that's happened is the fact that we're using words like impact crater. I mean, and praying the meteor doesn't hit us. I mean, so I think that, I said this earlier today, somebody said, fear is free. And I think that we have a lot of people doing really hard and important work. I mean, drug discovery, medical discovery is really hard. Diseases are hard to cure. And the fact that people who do that work and have chosen to do that for their life are feeling so unsteady or unsure that great universities are thinking we can't afford to continue to make the investments that we make in research, that academic health systems are questioning those investments. I think that's probably the worst of it. But I mean, economically, if this meteor does hit in our state, 1 out of 4 jobs are meds, eds, or biotech in our state. So it is not, this is not a theoretical problem we're trying to solve. It would have very real, very serious economic impact.
When you think about, just for a moment, suppose it were true that meds and eds and biotech did actually need some reform and the kind of funding that they receive, what would that have looked like? Like if you were to design reforms that didn't look like these big Trump cuts, what would they look like?
Yeah, I think the best example, I think, is sort of, business people hearing about 65% overhead, and they're thinking about how they run their own companies, and they think, well, that's a ridiculous number. Of course, that's just a sign of government waste. But if you think about how overhead rates, particularly are developed for universities or academic medical centers, they're driven off of sort of what costs are allowable. And so, for example, in overhead calculations in in an academic medical center, which I'm most familiar with, are things like wastewater treatment that the hospital wouldn't be doing if they weren't doing research, or cost of animal care, which the hospital wouldn't be doing if they weren't doing research. So it doesn't fit neatly onto your Medicare cost report, so it becomes overhead in an NIH grant. Now, the other thing I think people in the room know is that, or should know, is that some grants come in fully overheaded from the National Institutes of Health at about 65% on average around the country, and some come in with zero overhead. Grants, foundations, or foundation grants would be good at that. Training grants, which are sort of the seed corn of academic discovery, have an 8% indirect cost rate, and clinical trials are around 25 or 30%, and everyone's always trying to negotiate on that. So the effective overhead rate for a research enterprise is significantly less than that. So, you know, nobody wants to even hear what I just said about that, and I tried to make it short. You know, overhead's not a really fascinating topic, but I think that it's a great soundbite, and I think we should be much more clear-eyed as a nation about what biomedical research costs, what this life science industry that we've grown here, that's the envy of the world, actually costs, and call it direct costs, not indirect or overhead.
And I'm glad you mentioned the NIH overhead cuts. And recently a federal judge here in Massachusetts actually issued an injunction, and it's unclear so far whether the administration will appeal it. So the cap on overhead appears to be stalled for now. Does that mean that people who rely on NIH grants are out of the woods?
No, because not at all, because there was this was a multi-pronged attack. It was not only on overhead as a construct to fund research, but it's universities are facing potential attacks on endowments, which enables them to make investments in the buildings and physical spaces that people use to do this work. But I think the most insidious attack is the attack on grants that talk about things like gender biology. We've had grants rejected because it has the word justice in it. You know, there's literally a list going around of words you shouldn't put in grants. And so to me, the most chilling part is that, you know, I mean, if there's one thing we learned as a nation during COVID was that there are, you know, baked in health inequities by race, ethnicity, and gender in this country. We all saw it. And many people took very important steps to try to address it. And that work is, you know, chilled, silenced, stopped, unfunded, and that to me is the most. We'll get through the math and the money. I think I'm trying to find a better word than morals, but the fundamental rationale for why people are curious about things and investigate things. That's what worries me the most.
Have you seen? You've been, you know, in this kind of general public health space for a long time. Have you seen a weirdly kind of Orwellian emphasis on language like that ever take hold before?
No, never. And I've been doing this for 45 years. I've never heard anything like this. I mean, you know, look at the advances made against HIV across the world were made under George W. Bush. Nobody sort of hails him as a woke progressive guy. I mean, you know, but he understood that the United States has a leadership opportunity in this world and on this planet to help people, and did it. I mean,
I know that Governor Healy has expressed some concern about brain drain from Massachusetts, and just anecdotally, I dropped in on a scientist at MIT yesterday, and I'm not going to name her, but she said that she was actively looking at moving her lab possibly to Canada or to Switzerland. Is that something you're seeing?
You know, I've not seen it, but I'm pretty far removed. You know, I'm kind of a government bureaucrat, so I'm probably the last person someone would tell that to. But I think the chilling effect is sort of three ways. For Massachusetts specifically, and we've always had this tension, we produce a lot of brilliant people every year. Education is kind of our cash crop. And so we've always had the pressure of people going from soft money that they raise themselves to kind of land grant organizations, University of Michigan, University of Indiana University, states states that can give people hard money slots. Texas would be a good example of that. So we've always had that tension in laboratories and in universities in Massachusetts. What we're seeing now are two things. Foreign scientists who are a big part of the workforce who don't want to come here. I mean, science is global. I mean, people collaborate all around the world. And so we're seeing people who don't or can't come here. And then we're seeing people who are either going back to their home country because they don't feel safe here, or are being recruited to places that are competing for talent. China would be a good example of that.
In addition to research cuts, there's also been significant cuts to public health grants to the states, including, I gather, and you'll know the numbers better than me, but something like $100 million to Massachusetts. Yeah. And what sorts of, again, watching the news, a lot of that can seem really abstract. Like, what kind of programs specifically does that stuff support?
Yeah, so there was a $100 million cut to Massachusetts. It was $11 billion across the country. So, I mean, every Friday we have sort of support group of people who do my job around the country. It's Friday afternoon, and I guess it's Friday morning in Alaska. But and so every state was facing sizable cuts. Ours was $100 million. There's a temporary restraining order that stopped that, so those funds will continue. But the order read. Not the restraining order, but the cuts read that as of yesterday, you are to stop doing work in these areas because it was really weirdly worded, so forgive the dichotomy in the sentence. The American people are tired of the COVID pandemic, and it never existed anyway. It literally says that. And for us, it was COVID-related funds, some of which we knew was going to end at the end of this year, some of which we knew was going to end next year. But for us, it came in, I think of the money sort of in two buckets. One was to fund sort of the basic public health infrastructure in our state, local cities and towns reporting. If they weren't reporting on COVID, now they need to report on norovirus or, God forbid, measles. So the cuts hit those kinds of public health infrastructure in our state. Our rabies lab, for example. We were using the money, money's fungible, and it also, about half of it went to community-based organizations that were extending public health in ways that, think about people who buy air conditioners for low-income people so that their kids' asthma is in control. And so those kinds of, that was also cut. So it had a really chilling and reverberating effect across a public health landscape in our state. Now, we were able to stop that, but restraining orders eventually get lifted, and states have to balance their budgets. So it puts us in a very difficult position. Do we keep spending as if nothing's happening, or do we kind of pick a middle ground, or do we hunker down? And that goes back to my early comments about fear being free. I mean, you find yourself thinking about things you would never think about in the normal course of business because the other choice, if you don't make this choice now, you could be facing other choices down the road that'll be so much worse.
Let's talk a little bit more about the legal strategy. You mentioned that temporary restraining orders are temporary, and we talked earlier about the NIH injunction. How well have the courts kind of performed in your view? Like, how much has that been a kind of barricade for you all?
So I should preface this by saying I'm not a lawyer. All my legal experience is formed by many hours of watching Law and Order, but everybody does it. So, but I'm actually kind of pleasantly surprised that the courts have held, because I think the constitutional principles around impoundment in the three branches of government are pretty clear and well understood by people, but by jurists on both sides of the aisle. But I don't think it will hold forever. And I think they'll find other ways, which gets back to that fear factor that I was talking about that makes it hard for, I won't even call ourselves policy makers. We're kind of policy reactors these days for us to think about, okay, what do we do if this happens?
I hate that this conversation has like a structure of a parade of horribles, but we're just going to continue through that parade.
There's only 17 minutes left. Yeah. I can see the clock.
That's a bit of stagecraft that's supposed to be invisible, so no.
Oh, okay. Sorry.
Look, Congress is also considering serious cuts to Medicaid, And I just want to know, again, like thinking of Massachusetts as sort of a test case, like how much does your population, your citizens, do they rely upon that? And what would that look like if there were significant cuts?
Sure. So just to set the stage, Massachusetts is a state of over 7 million people. About 2 million people in our state receive their health insurance through something called Mass Health, which is our state's Medicaid program. It covers about 48% of the kids in the state, pays for 50% of the people with disabilities, and over 70% of the people in long-term care. So it's a very important part of the insurance fabric of our state, and by doing interesting things with the Medicaid program through an 1115 waiver, our state was the first to go forward with basically universal access for all. 98% of the people in our state and virtually 100% of the children are covered. So it's a great state to live in and get health care and work and all those things. A little expensive and cold in the winter, but from a health care standpoint, things are good. The Medicaid budget is a little over $20 billion. Health and Human Services is $33 billion. That's half of the state budget. So when I think about the people we serve, it's our job to try to manage those dollars as prudently as possible. But if you think, and the people that we serve need public transportation to work and public schools to work, and they need housing. And so we really work to try to, make the Medicaid program help people live the lives they were meant to live and be productive members of society. That's our goal. And so that they can be independent and resilient and get the health care that they need. A 10% cut on $20 billion is $2 billion. We can all do that math. $2 billion is a very sizable cut. And when we look at what's available to us to cut, it's rates to providers. And you could argue, well, we have great hospitals in the state, they could take a rate cut, but half the hospitals in the state have never really emerged from COVID and still have red ink on their operating statements. If you turn to the long-term care sector, which Medicaid largely funds, the story is even more grim. We have about 18 nursing home chains in or close to receivership. We have a nursing home receivership statute in this state. I think 43% of the nursing homes in the state have less than 5 days cash on hand. So when I look at that sector, we probably can't go there. We want more access to primary care in ambulatory setting. We probably can't go there. We are the life science capital of the world, so we have to think very carefully and clearly about how we address the rapid growth of pharmaceutical prices, because many of those $2 and $3 million cures were developed right here with companies that pay taxes and hire people and do all those things. So it's that $2 billion cut, which is I think a likely number, is really challenging. What we think they'll do is and let me just say one thing. The other area that worries me a lot is our Department of Transitional Assistance, which serves about 1 million of the lowest income people in the state through cash assistance which the state provides with some federal match, and SNAP benefits, food stamps, supplemental nutrition assistance program. That's $2.7 billion in the state, all of which comes back to retailers because people buy food. They buy it at a local bodega, they buy it at Stop and Shop, they buy it at Walmart. I mean, $600 million of SNAP dollars are spent in our state at Walmart because Walmart actually has fresh fruit, vegetables, and good prices, and low-income people know that. So as we think about a SNAP cut of 10 or 20%, I think not only about people will be hungry and unable to feed their families, but there's an economic impact to that. So we're trying to translate Medicaid and SNAP and DTA cuts into jobs because we think the economic argument might win the day with this administration. We know they will come back with work requirements. Now that experiment's been run several times in the course of since we've had Medicaid. Most recently, Georgia and Arkansas had a work requirements as part of their Medicaid waiver, and it kind of failed. 60% of the people on Medicaid in our state are working. The people who are not working are either severely disabled themselves, caring for somebody severely disabled, or young children. So it's kind of a false promise, but one I hope they'll let us try, because I'd much rather take a work requirement, I don't want to say charade, we'll work really hard to do a good job with the work requirement than a flat out cut.
hearing you kind of tick through those like available buckets of money and services, it strikes me that it sounds like you're pretty far down the line of thinking in terms of contingency planning for cuts like this. And that just makes me wonder, like, in this general political atmosphere, like when you think about the pie graph of your time, how much is being spent just like planning for really the worst coming from the federal government versus just like actually running the state day to day?
That's a good question. I haven't thought of it as a pie graph. You know, I think that the governor's been really clear about this with all of us. Doesn't want us to overreact, doesn't want us to underreact. She's been very clear that we need to find ways to work with the Trump administration. A lot of the programs that we're very proud of and have built in the state are federal-state partnerships, and we need to figure those out. We also need to stand up when something is not aligned with our values. So for me, I think it is more about, and maybe this reflects my sort of petty bureaucrat mindset, but I think it's about the mechanics of how we respond is kind of my job, because I kind of don't have the luxury of thinking, you know, we're going to protest our way out of this. Like, I know who we serve, and I don't know them, everybody personally, obviously. I don't know 2 million people, but I know that the work that we do, sure, there are ways we can do it better. Sure, there are opportunities, there's redundancy. I always argue within our own agency that we're, you know, that's a DCF kid, that's a DMH mom, like, we can do better. They're all people we're trying to help. But, you know, I think that we need to be very clear-eyed about where we take cuts. And I think our job is to really convince people, you know, people build these programs and they fight for them and they build their careers around them. And it's very hard for people to change how they work. And I think we can't waste this time thinking we're not going to change, because we're going to run out of time. Yeah. And money and runway. And then we'll do what government always does, which is put people on waiting lists, slice the bologna thinner. We'll all have food in our bellies, but the people we serve won't.
Before taking this job, you were CEO of Boston Medical Center for some 13 years. That I expect gives you a much more kind of granular view of like the whole kind of healthcare experience for the average patient. And if you were to say where the average patient walking into Boston Medical Center would first come into contact with these cuts in the coming months or years or whatever it might be, where's that going to happen? Where are they going to feel that? And I'm asking partly politically too, like what are the things to highlight?
So I think Boston Medical Center may not be the best example, because I don't think we ever turned anybody away. But, and we were sort of known as a place to go when you had nothing else to do. But I'll give you a really concrete example. In 2008, 9, 10, you know, after the Great Recession, Massachusetts had expanded coverage for all, and the Medicaid program was really struggling to make ends meet, much like we'll be doing shortly. And I remember every Monday morning, there was this incredibly long line in the lobby. And I'm like, what is going on here? And it was people who were waiting for what used to be called the tooth pulling clinic to open up. Because at the time, Governor Patrick had to cut adult dental benefits for Medicaid to make ends meet. So people literally around the state would like, the line was out the door for people to get basically teeth pulled by dental students from the BU School of Dentistry. Like that line's gone. I mean, the dental clinic at PMC is fantastic. I get my dental care there. It's the best dentist I ever went to. You know, and it's like stuff like that just kind of get you. You know, people who, there was an article that the Boston Globe did a couple years back that talked about food insecurity and that how much work it is to feed your family through pantries. Taking multiple buses, knowing what pantries are open on what days, lining up early. Like, it's a full-time job. So I can see that being being something that people will struggle with. And Boston Medical Center had a food pantry. Doctors could write a prescription, and you could go get the 3-day emergency supply of food, because that's the kind of hunger we see in our country. It tends to be episodic. So I think hunger, we'll hopefully keep school lunch, which is free in our state, which it was one of Governor Healy's early actions as governor, which has really helped stem the learning loss that we saw during COVID, because kids can't learn if they're hungry. We did summer nutrition programs, which I think we'll hopefully be able to keep this year. We haven't heard that it's canceled. I think about basic needs, and I also think about, Massachusetts is a unique state. We don't have a lot of medical debt. We don't have a lot of uninsured people. But I think about what that will mean. People will defer care, and they'll present with much more advanced stages of illness, which always happened at BMC anyway.
The measles vaccine was famously developed right here at Boston's Children's Hospital, and I gather that. Or I know that there's been a funding cut for vaccine research as well, but even independently of that, I wonder, in recent years, or at least since you've been in this job, what do the numbers look like for vaccine uptake in Massachusetts?
So Massachusetts, I'm going to knock for Mike or glass or my own head. We're very proud of our vaccination numbers for flu. COVID was a little soft this year. We're very happy with our measles vaccine, but again, got to knock wood. I think the most chilling effect that came out of COVID, and I can't explain it other than, I just can't explain it, because it is, if you think about the early days of COVID, the people who were taking care of patients, there were parades and people were like clapping when they walked home from work at night. And then like less than a year later, they were like getting water bottles thrown at them at town meetings when they said, you should mask up and get vaccinated. And I don't understand where that destruction in belief in public health got destroyed. And there's been a lot read. This magazine's done a lot of work on that. And I think we just have to get back to really understanding that the benefits of, we know that these viruses are colorblind. They don't know whether you're in Massachusetts or Vermont, and Vermont has a measles outbreak right now. I don't understand it, but it is the single biggest shift I've seen in my career, is not trusting the people who take care of us. And that doesn't mean you shouldn't advocate for yourself, and you shouldn't be you shouldn't be thoughtful, and we all Google stuff. But do we still call it Google? But I don't know, ChatGPT stuff. But I still think that there's some fundamental distrust that's been built between people in authority. You see it with universities, you see it with science, you see it with, are we going to join the Flat Earth Society? I don't understand it.
Are you doing contingency planning for a measles outbreak here?
I think hopefully we would just take care of patients who go on to develop, just like we would any other disease. We had a really rough flu season, and some COVID this winter, and hospitals were really at capacity on the adult side. So usually the contingency plan is you move, kids into adult spaces and adults into kid spaces. We did that during COVID because kids mercifully were kind of spared. So we'll go the other way in this one.
Secretary Walsh, I hope that next time we get together is for a much sunnier conversation and sunnier day too. But thanks for being with us this morning.
Thank you for having me. Thank you.
Please welcome the Atlantic's publisher and Chief Revenue Officer, Alice McCown.
Hi, everyone. I'm Alice McCown. I'm Publisher, Chief Revenue Officer. We hope you enjoyed this morning's discussions. We're thrilled to have you here. I'd like to thank all of our speakers for the thought-provoking discussions. We're going to head into lunch and networking. If you go here to the right, we will have lunch in the Harborside room. It's just out that exit. At 12:30, please join us back here on the main stage for a conversation on the future of Alzheimer's disease diagnosis produced by our underwriter, Eli Lilly and Company. And then at 1:15, we will be back here on the main stage for our afternoon session. We'll see you back here later this afternoon. Enjoy.
The program will begin in 5 minutes. Please take your seats. The program will begin momentarily. Please take a moment to silence your cell phones. The program is about to begin. Please welcome back to the stage the Atlantic's Alice McCown.
Hi, everyone. Welcome back. We hope you enjoyed our conversation so far. We're excited to continue this afternoon's programming with sessions about the future of pain management, innovations in organ transplantation, and AI and drug discovery. Before we begin, I want to thank our underwriter, Eli Lilly and Company, for their support of the Atlantic's journalism today. Now, let's get started.
Here to discuss the future of pain management, please welcome David Altshuler, Executive Vice President and Chief Scientific Officer at Vertex Pharmaceuticals, with the Atlantic's Sarah Laskow.
Hello. Well, thank you again for being here.
Thank you for having me.
Well, I'm excited to talk about all the interesting things you guys have been doing. Just this January, for the first time in 25 years, the FDA approved a new type of painkiller, which is I don't actually know how you want to say this, but Journavx.
Perfect.
Yes, okay. And what's so exciting about this drug is that it's a non-opioid, non-addictive treatment for acute pain. Can you just explain to us, how does this treatment work and how is it different from opioids?
Absolutely. As we all know, pain is something we experience in the brain. But if you understand where it came from, sometimes it can come from damaging a tissue, like you have an accident or you have surgery. You can also have it because you have a nerve that sends a signal to the brain. It's called neuropathic pain. And then, of course, there's the sensation in the brain. What opioids do is they don't actually stop the signal from getting to the brain. They change the brain reward center. So despite sensing the pain, you just it doesn't bother you in the same way, but that's why it's impossible to separate the addictive potential from the medicine. What our medicine does is it's the first medicine that blocks the sensing of pain, the peripheral signaling from the tissues up to the brain. And in doing so, the hope is that you can reduce the pain without any of the side effects or addictive potential of something that works directly in the brain.
Yeah. And can you explain more about the addiction question? Like, how do we really know that that means it's not going to be addictive?
Absolutely. So, first of all, addiction is something, again, I think we all know that happens in the brain. It's how you feel and how you sense. The way our medicine works is it inhibits something called NaV 1.8. Now, what that means is something called a sodium channel, which is how electrical signals are produced and travel from the periphery up the nerves. And NaV 1.8, the target of our medicine, has been called for some time the holy grail of pain research for like 20 years, along with its partner, something called NaV1.7. And the reason is because it's only present in pain-sensing neurons, nowhere else, and it plays a central role in sending that signal. And what our medicine does is it inhibits NaV1.8, but it doesn't interact with any other signaling molecules, and so it can reduce the pain signaling without other effects. And in particular, with regard to the brain, we recently published a paper looking at a public data set that had tissues from the brains of many people and could not detect a single example where that NaV 1.8 was present in the brain. So the medicine acting only peripherally, only on this one target, is why we're confident it would not have any addictive potential.
Yeah. And are you like watching in any way for that? Do you have to like worry about that?
The medicine's approval says it's for moderate to severe acute pain. But nonetheless, of course, any new medicine is followed carefully in terms of what could happen, but there's no specific requirements to do that.
Yeah. So let's like zoom out a little bit and think about like how do you even get to a place where you're creating a drug like this? Like you guys actually have had an incredible 85% success rate in getting to this phase 3 clinical trial. The industry average, as people here probably know, is like 10%. And, you know, like I know from our coverage, like you've been doing incredible work in these many different areas: cystic fibrosis, sickle cell disease, acute pain. So like, what is your approach that allows you to do drug discovery across all those things? And do you think you're doing something different than other people in the industry?
I do believe that our strategy is unique.
Yeah.
And it started about 10 years ago when I joined as Chief Scientific Officer and working with Jeff Leiden, who was our Chief Executive Officer, now our Executive Chair, who's also a physician scientist like myself. I used to be a doctor at Mass General. And what we had observed over decades was that the biggest problem in drug development and discovery is actually not efficiency, although it's important. It's actually failure. That 95% of all new potential medicines that enter clinical trials, 95% fail. Only 5% succeed. And why is that? And our study of that was, there are many reasons, of course, but a major one was not picking the right medicine for the right target for the right disease. Most programs come from studies in a laboratory of a mouse or a fruit fly or a cell in a dish or a model or even an AI model. And all of that has uncertain relationship to human beings and disease. But if you base your programs on those rare cases where there's a serious disease that affects people, that we know what's wrong and we know exactly what causes it, we believe that if you could make a medicine, that would have a higher success rate. And so we picked cystic fibrosis. It already existed at Vertex. Sickle cell disease, what became the first approved CRISPR medicine, pain, type 1 diabetes, cell therapy, these examples. each of which society understood, medicine understood exactly what caused it, but we had to innovate in how to make the therapy. And we thought if we could do that 10 years ago, we'd succeed at a higher rate. What we've seen is that of the 8 programs we put into the clinic since then, 3 are now approved medicines for CF, pain, and sickle cell, and 4 others are in phase 3 trials as potential first-in-class medicines. So I think that it does underscore the idea, which is a little contrary to how most people talk about it. This is not a business and a science only based on a technology platform. It's not a business that's based only on a sales force or particular organ. It's actually picking the right problem, the right target, and the right medicine. And if you dedicate yourself to that, you can have a much higher success rate than the industry does overall.
Yeah, and it sounds like one of the kind of things that cuts across all those diseases that you talked about is that you understood the cause. Does it matter like what the mechanism of the cause is, or just that we understand it at all?
It's a great question, and one that actually often creates debate. What does one mean by causal human biology?
Right.
Well, in my mind, actually, causality is very clear. Causation means that it influences the outcome. It's not caused by the outcome. All right, so if you think about it, if you have cystic fibrosis, that happens to be caused by mutations in a gene called CFTR. But the actual disease, of course, also includes infections in the lung, thick mucus, scars in the lung. Now, you can have a therapy that is effective, works very downstream, like an antibiotic, and it can help the patient, but it doesn't reverse the underlying process. But if you can get at the cause, then you can. And so the ways we at least define causality are human genetics. If there's a gene mutation someone affects, whether Mendelian or it can be more complex, an experiment done in a human being like transplant of cells or even pharmacology, but something done in human beings, not extrapolating from models.
Yeah, that is interesting. This just made me think that I have to do a quick plug for a story that my colleague Sarah Zhang wrote about the cystic fibrosis medication, and it starts with this like incredibly vivid description of the mucus problem, and that you just don't have when you take the medication. It is like quite remarkable how much it changes people's just experience of the disease.
It was a wonderful article, and for those of us who spent a long time working on it, and of course you do work in a laboratory, you don't get to spend all the time with the patients. It was really a wonderful story to read.
So how does pain fit in all that? Like, how did you identify pain as an area?
It's a great question, because a lot of people look at what Vertex does and they say, okay, cystic fibrosis and sickle cell, those are genetic diseases.
Right.
And they go, pain, that's not, what is that? The key reason that we work on pain is because about 15 or 20 years ago, human genetic discoveries were made that showed that these two, what are called channels, these two proteins, NAV1.8 and NAV1.7, were central to pain. The one that's easiest to understand is for the other partner, which we also work on, NAV1.7, but it's not yet in the clinic. There was a family that were fire walkers. They could walk on coals, and they could feel the sharpness of the stones, they could feel the temperature, they could feel their ankles moving, but they felt no pain. They had something called congenital insensitivity to pain. And a scientist in academia discovered that they lacked the gene NAV1.7. That if you inherit 2 copies of that gene that don't work, you have no pain, even though everything else is basically fine. And it's not just that one family now, there's hundreds. And then it was also figured out that if that protein is turned on, you inherit a mutation so it's always on, you have inherited neuropathic pain, lifelong burning pain. That's also true of NAV1.8. And finally, the biologists had worked out that these 2 proteins work by signaling pain and nothing else. So 20 years ago, like every pharmaceutical company and academic labs all said, we got to go do that. And by 2015, they had tried and not succeeded, so they basically all stopped. But our scientists were kind of, we've been working on CF for 25 years, pain for 25 years. Vertex is very resilient and committed when the project is great. And so in this case, everyone else kind of stopped and we didn't. And then we were able to crack the problem being that in order for this to work, it has to be an incredibly specific and effective medicine. If it's not specific enough, it can interact with other parts of the body and cause side effects. Right. And our scientists in San Diego were able to figure out how to make it so selective, so precise, that it only limits the pain, it doesn't have these other effects.
Yeah, wow. I do think like when we start to talk about pain, it does start to feel very like heady. You know, when you talk about the fire walkers, you're like, okay, well, they're still walking on fire. Like,
yes.
What even is pain if they're not experiencing anything?
Yeah.
I just wonder, how do you guys think about that? Like, is pain a symptom of a disease? Is it the disease itself? Like, what do we mean by pain?
It's a great question, and it's one of the things that actually makes it difficult to study pain, and why I think many companies stopped working on it, but we continued, is because ultimately today, pain is subjective.
Right.
Meaning, if you imagine you're doing something for cancer, you can take an MRI or a CAT scan or a biopsy. If you're studying cystic fibrosis, you can measure certain laboratory measures. But in pain, you basically ask somebody on a scale of 1 to 10, how does it feel?
Yeah.
And of course, people don't just feel pain. They can feel sensation, they can feel pressure, they can feel movement and all that. And so it is challenging. And that's one reason why we think it's very important not to consider pain as one thing, but actually as multiple different things.
Yeah.
In some cases, what's called neuropathic pain, the pain itself is kind of the cause, the nerve not working. And in other cases, the actual problem is, let's say you broke your leg or you had surgery, and the pain is not the cause, but we all know that at least if you've had your surgery done or you have something for you've been treated for your broken bone, we want to limit the pain until you've healed.
Right, yeah. Should we start talking about pain differently as like different things? Like, are we making a mistake by lumping it all together?
I do think it's important to think of disease based on the underlying biology. I'm kind of like, this is a religion for me personally, of think about the underlying cause, not just the outcome. So I'll give you an example that is about what you're saying. 100 years ago, if someone had shortness of breath, that was a disease.
Yeah.
But then they figured out, well, you could have pneumonia. You need an antibiotic. You could have asthma. You needed a bronchodilator. You could have cystic fibrosis. You could have other things. And if you treated them all the same, something that would work for one disease might not work for another. And you could consider that what people call precision medicine. I think in pain, it's going to matter which element it is. But we are very encouraged by the fact that we have done clinical trials over the last 10 years, this NaV1.8 mechanism, in multiple different acute pains, like injuries, but also in neuropathic pain and in diabetic peripheral neuropathy, which is, there's 2 million people in America with diabetic peripheral neuropathy. We're in phase 3 because we had a positive phase 2 study, and we've also studied other kinds of pain. So this does seem to be broadly relevant, but it is important to recognize these are not all the same thing.
Right, yeah. I think that's like basically what I want to ask you next. Like, what is on the horizon for you guys? Like, how are you going to build on this?
Yeah. So I really do believe this is the beginning of a new era for pain medicine and pain treatment. Not just Genetics, but the fact that this is the first time it's been shown that peripheral specific nerve blockade, just blocking pain sensing neurons and nothing else, can have effective pain relief with a better safety profile. And at Vertex, our approach is what we always call serial innovation, which is not just to make one medicine and try and sell it, but have one medicine and bring it to patients, but a second and a third, because the history of medicine is the first thing you do is almost never the best. It always, you learn over time. So we already have our second NaV1.8 inhibitor that's called VX993. They start with numbers, they only get names later. That VX993 is already in phase 2 for both acute pain and neuropathic pain. And then we also have multiple other molecules, both for NaV1.8, and we've been working so hard, and I think we've cracked the biology of NaV1.7, which is not yet in the clinic. We're getting close. And we think that, I believe that the combination of NaV1.8, the best possible medicine, which we hope to make, and then NaV1.7, where we're not yet in the clinic, that those either alone or in combination are going to I'll just say 10 or 20 years from now, because investors always want to know exactly when. I don't know exactly when, but if you ask me, will it be the case 20 years from now that people treat pain with peripheral pain blockade based on highly selective medicines for NaV1.7, 1.8, or the combination? I'm very confident. Unless there's some problem that's not envisioned and not been found by human genetics, I think it's going to completely change pain treatment. But that's going to take, obviously, a lot of work and a lot of clinical trials and work in society to achieve.
Yeah. What's kind of like the inverted way to think about it? Like, is there parts of pain that you feel like you haven't cracked yet, like where you wouldn't recommend this medication for me?
It's a great question. I think that, again, one has to think about what the underlying cause is. So let me give you a sort of simple example, is if somebody had, let's say, really bad bony problem. Let's say they had really bad arthritis, such that they had their knee, bone on bone, and you reduced their pain so much that they kept walking on it and damaged their knee. That would be a mistake because they need that pain to sense what's going on. So I think, in my mind, when you have acute pain treatment and the medicine is approved for moderate to severe acute pain, that's based on a physician working with you and saying, we've treated your broken bone, or we've treated your burn, or we've treated your surgery. Now we want to help you feel less pain while you heal. Or a physician saying, and the patient deciding, my diabetic neuropathic pain, we're doing what we can to protect my body, because you can have numbness, you can have, I used to be a diabetes doctor at Mass General, but then only treat the pain. And so I do think it's important to think about it. And today, that's already the case. I really believe in the FDA and regulators and also doctors and patients and governments all saying, okay, you've shown us this data. Now the doctor and the patient decide, where to use it, but it is important to make sure that you're treating the right patient and not missing something that needs a treatment before you treat their pain.
Right, and how do you end up thinking about that in terms of chronic pain? We've talked a lot about acute pain.
Yeah, so as I said, we've done, I think, let me just check. I think we've done 5 clinical trials or 6 clinical trials between Genavix and a predecessor molecule in acute pain. Every one of them has been positive for different types of surgery, and also, and so that's why the label is broad. Sometimes labels would say like for knee pain or shoulder pain, and the FDA gave us a label for moderate to severe acute pain. With now other types of pain, we have to do the clinical trials. In the end, you have to do it. And so, as I said, we did a clinical trial in diabetic peripheral neuropathy. That's 2 million people, and it was, now we're in phase 3. And we're doing trials. We did a trial in another type of pain called sciatica, and it didn't meet the criteria we were looking for, but we're not gonna stop, because Vertex doesn't stop. We're going to keep working, because there's 4 million people with that. We wanna try and help them. And we'll keep doing that with other kinds of pain. This is the beginning, not the end. But in the end, only clinical data can tell you whether or not it's helpful or not. That's critical.
What were the criteria you were working on for sciatica? Sorry.
Yeah, we're just looking. Obviously, there were a set of criteria, and you need both effectiveness and separation from placebo. And we did not achieve everything we thought was desirable. But having said that, the 4 million people with sciatica, there's no approved treatment for them. And there's actually never been a phase 3 study, let alone a positive medicine. So for Vertex, we don't give up. It doesn't mean we take for granted anything, but we're gonna keep working to try and help them, just as we tried to work. We've been, if you think about CF, we started in 2012 with our first medicine for 2,000 people. We just launched a Liftrec 2 months ago, and we now have 5 medicines on the market that are approved for 90% of people above the ages they've been tested in. And so, again, we see this as early days, and we are gonna keep learning from the things we do and innovating until we can help as many patients as possible.
Yeah, what are your long-term goals for the CF drug? Like, what kind of penetration would you like to see among patients?
Well, so CF there's over 90,000 people in CF, and our CF medicines are approved for about 90% of them in each age group. You have to test medicines in younger and younger ages, but for example, Trikafta, which is was approved in 2019, is approved for ages 2 and above. And Liftrec is the newest one, is approved for 6 and above. And it's in fact approved, like I said, for about 90% of people above those age ranges in the US, Canada, in North America, but also in every country in the EU, in Australia, New Zealand, et cetera. And so what we're working on is, 1, to continue to bring even better medicines if we can to achieve the highest possible benefit. But also, there's about 5,000 to 7,000 people in the world who have CF who don't respond to our medicines because they have a mutation that doesn't respond. And we're also working on therapies for them because we're really committed to trying to help everybody with CF.
Yeah, and I remember from our reporting that there's also people who are interested in applying the drugs to even younger than 2, even for moms who know their kids have CF before they're even born.
So one of the things I learned, and I was an academic and a professor before I moved to Vertex 10 years ago, and I didn't know all this at the time, but it's appropriate. The way you can get medicines approved, you have to start with adults and then do clinical trials in younger and younger. It took us 10 years to get from the first approval of Kalydeco, which is the first CF medicine, to the approval for age 1 month and above. which is where we're now approved for those patients. And the reason is you do a clinical trial, let's say, for 12 and above, and then 6 to 11, and then 2 to 5, and then 18 months to 2 years, and 12 months to 18 months, and 6 months to 12 months, then 4 months to 6 months, literally, all the way down to 1 month. And that's how it should be, because you want to make sure these children are safe for them. So we continue to work on that, because the earlier you can treat, we think the better the outcome will be.
Yeah. No, I mean, when you think about it, it is truly life-changing, I think, and the idea that there are kids who would be born with this disease who just would never have to deal with it is actually quite heartening to think about.
It's pretty remarkable. I will say, when I started medical school, which is amazingly 39 years ago, I don't feel that old, but I guess I am, the average age of someone with CF that they would survive was in the 20s. Yeah. And of course, 30 years before that, it was in the 8 to 10 years old. And by now, it's been estimated that in the absence of our medicines, it would be in the 30s, the age of the average lifespan. But a paper was published 2 years ago based on the fact that real-world evidence has shown that on Trikafta, the reduction in the death rate is over 75%, the reduction in hospitalizations over 75%, the reduction in transplants over 75%, that the life expectancy, if you start Trikafta above 12, this paper published, was 83 years.
Yeah, wow.
And so it's actually completely changed. And the only thing I remember seeing myself in my career was when I was an intern and resident at Mass General in medicine, a substantial fraction of people there were HIV patients, AIDS patients, and they were all young. They were usually in their 20s, and 100% of them died, usually within a year or two. And it was so unbelievable to be there. I mean, obviously much worse to be them or their families or friends, but to be in the hospital every day and see that. And then when Crixivan was first discovered and developed by Merck, which was the first highly effective triple therapy, you'd see patients get out of bed and go back to work, and the life expectancy went back, and it was mind-blowing to me. And actually sort of inspired my whole career was to see something that lethal be turned into something where the people's problem is that they have to figure out now, they have to cope with the fact that everything's changed and remake their life, but they're feeling so much better. That is unbelievable.
No, and I remember talking to Sarah Zhang, who wrote the cystic fibrosis story for us, about exactly that. What is it like to think you're only going to live till 20 and then to all of a sudden be told you're going to live to a normal life expectancy? How do you even readjust your sense of what your potential for your life is, and just trying to understand the human experience of that, I think, is quite profound.
It really is, and that article was very good. There was one in the New York Times about it. There are others, and it's not only cystic fibrosis, it's any condition that was so life-threatening, and the rare case where there was a condition so life-threatening and then people can, really transform their life. As we all could imagine, that's not a trivial thing. I think sometimes people's expectation is there wouldn't be any psychological stress or any changes, but the reality is that, of course, a complete shift in your perspective of life is challenging for people, but that's where family and that's friends, doctors, the community all come in. I was somewhere working with some people last weekend from Silicon Valley, and sometimes they say, we won't have doctors in the future, we'll just have AI. And I think to myself as a doctor, therapies are good and diagnoses are good, but if you're a human being suffering and you have pain or you have something, you need human beings, not just doctors, but nurses and friends and colleagues. And that is the ultimate basis of medicine, is the humanity of working together. But if the humanity is not enabled by actually being able to help the person, it's a lot harder than when you can not only talk to them and help them work through it and cope with it, but also say, and I can help make you better.
I do hear that AI is good with helping with differential diagnosis.
No, it can be very helpful, but it's not going to replace human beings.
No, I agree. I think we have some time for questions, if people have questions. If not, I can ask more.
The question was, what medicine excites me the most in our pipeline? And that's a big question in biotech and pharma, because most companies have hundreds of programs and they want to see which one works. We only have a handful because we only do the ones we're super excited about. That's part of our strategy. But having said that, In addition to, I do think this pain and sickle cell and CF are amazing, there's a few on the horizon. I'm a diabetes doctor by training, and we have a program now in pivotal development called Zemilacel, which is a human stem cell derived islet replacement therapy. So type 1 diabetes, the childhood form or early onset, not type 2, affects about 4 million people in the US and Europe, and is caused by an autoimmune, your own immune system, destroying the islets that make insulin. And for 100 years, since Banting and Best discovered insulin, it's been treated by injecting insulin. And if you don't take your insulin for a few days, you actually can go in the hospital and you only live for weeks without insulin. So it's really was an amazing advance. But the problem is, even today, people with type 1 diabetes, every hour of every day, they have to be thinking about their insulin, their diet. They have to worry about if it's too much insulin, they can have low blood sugar. If they have too high blood sugar, they have complications. But about 25 years ago, it was discovered that you could take islets from someone who passed away, called cadaveric islets, and you could do a transplant, and you could basically cure their type 1 diabetes in a fraction of people. I know the next session, I think, is about transplants. Yeah. But the problem was that you could only get those islets if there was like a donor, and it turned out there were only like 50 or 100 donors a year who could produce islets. So a man named Doug Melton, who was now works at Vertex, but for 40 years he was a professor at Harvard. He has 2 children. I think he doesn't mind if I share this, Sam and Emma, who have type 1. And about 25 years ago, he switched from what he was studying to say, is it possible to make islets to help these children? After 20 years, he founded a company with Felicia Paliuca, who is still also works at Vertex, because they had figured out how to make the islets, and it was called SEMA, for Sam and Emma. And when they got near the clinic, Vertex bought the company. Doug and I have known each other for 38 years, and so we've been talking all along. We entered the clinic, and the data presented at the American Diabetes Association showed that of 12 people treated, 9 were off insulin with their blood sugar in the normal range, and the other 3 had reductions in insulin and improved blood sugar. And so now, working with the FDA and other regulatory agencies, we're in what's called pivotal development, which means that if we have to treat, we've agreed 50 people and then follow them, and that if that's positive, we are planning that we could possibly submit as early as next year for approval. And so this is an incredibly exciting thing. Now we also have some kidney diseases and other pain studies. We've got a lot of other things, but type 1 diabetes, the idea, having cared for over a decade, people with Mass General with type 1, the idea that the potential is there. And the initial study, I should be clear, is only for a subset of people who have very severe type 1, and it's not for everybody. But just like pain, if we can get that door open and start doing that, then I think the rest of it becomes engineering rather than science of how you make it better and better for more and more people. So that's an incredibly exciting program.
So we had a recurring theme. We had a bit of a recurring theme today around the regulatory landscape, and you have to deal with that a ton. Imagining that you might be involved in, let's say, the hypothetical tearing down of some of that infrastructure, what would your wish list be of things to change, and what would you pound on the table to protect as sort of the secret sauce of what works today?
It's a great question. So before I joined Vertex, I'd only dealt with the FDA once as on a scientific advisory committee, but we've had we've had like 6 drugs approved since I joined, and like this morning I was on a meeting preparing to discuss with the FDA. So I work with the FDA all the time, and it's an incredibly impressive organization. The people who work there are so dedicated, so experienced, so hardworking, and I think that it's great to work to try and make it as efficient and effective as it can be, and to do that while maintaining the excellence. But I do think it's critical. It's the leading regulatory agency in the world, and many follow it. And I think maintaining its excellence and making sure that that continues is going to be key to healthcare and patients, because they've done a great job. And I think you can always try and improve, and I'm in favor of trying to improve things that can be improved, but I'm incredibly impressed by the FDA.
I think we have time for one more if anyone. Oh, yeah.
Is there anything about trial design?
The question is about clinical trials for pain and what have we learned. And what I'd say is one thing we've learned is it is challenging to do clinical trials in pain because of the subjectivity of the response and also the fact that there are different patients that are heterogeneous. I'd say that we believe that we get better and better every time we do it. We learn things. There's no like one magic thing I can tell you, but like anything else, it's one reason we believe in serial innovation. Is because, it's a case, unlike, in some parts of pain, like acute pain or diabetic pain, actually it's pretty well established. In other kinds, we have to develop it, and that's part of Vertex's innovation, is not just in science or the lab, it's in clinical trials, it's in how we manufacture the medicines, work with regulators, bring them to patients. Everything requires innovation. I think clinical trials for pain is an area where our hard work that's going on today, hopefully over time, will lead to better outcomes for patients.
Well, thank you so much for being here.
Thank you so much. Thank you.
And now for a research spotlight on the first genetically edited pig kidney transplant into living recipient, please welcome Leonardo V. Riella, Director of Kidney Transplantation at Massachusetts General Hospital.
Thank you. Thank you. It's a pleasure to be here and talk a little bit about science and medicine. And we had a very special topic to discuss. But I'll start with some statistics. So there's 17 patients that die every day waiting for a kidney transplant in the US. And if we look at our list, we have now more than 100,000 patients that if we had a kidney today, we would transplant them. However, we only have about 25,000 kidneys a year. So there's a huge gap in terms of what's the ideal treatment for these patients that have a kidney failure, that fail, which is transplantation, versus our ability to actually do that. The problem with this is that our patients then have to wait on dialysis. The average wait time in the US is about 5 years. And while they are on dialysis, their risk of dying is 6-fold higher than getting a transplant. And if we quote what many patients would describe dialysis, they would say, it's pretty miserable. Why is that? Because they have to go to a dialysis center about 3-4 times a week, stay connected to a machine that's filtering their blood for 3 or 4 hours. And on the days where they have those treatments, the rest of the day is basically useless because they feel weak, they are tired, they just want to sleep. Many of our patients cannot work, they cannot travel, and they cannot even have a normal meal with their family because there are a lot of dietary restrictions. So now, imagine if we could grow organs. And there are a few different ways of thinking about it. You can think about bioengineering a whole organ in the lab. But what we're going to be talking today is about xenotransplantation, which is transplanting an organ from a non-human species into humans. In our case, would be genetically edited pigs. And this is not science fiction. It is happening now. In March 2024, we performed the first ever pig-to-human kidney transplant into a living patient. It was a major milestone because people have been trying to transplant pigs into humans for more than 60 years, and most of these pigs will only survive either hours or a few days when transplanted into humans. And there were a lot of hurdles to overcome. And this is just an image of what happens when you connect a kidney into a monkey in this case, and the kidney pinks up, it looks really nice, but within 5 minutes, this is how the kidney looks. It just clots. It becomes like, dead tissue very, very quickly. And the challenges that occur and why this happened is that there are certain incompatibilities between the pig kidney and humans that ended up causing that. And why pigs? And this is a question that always comes up. Why not monkeys? And there are a few reasons where pigs are the best candidates, donors for humans. One of them is that they have very similar size and function. But most important, their gestation is 3.5 months. They give about 6 to 12 piglets with average gestation, and by 1 year, we can use the transplanted organ, which means that you can scale things up in a very dramatic way. And we already use certain pig materials into humans, such as heart valves. But there were challenges when we talk about heart valve compared to an entire organ, such as the kidney. And there are certain things that we learned over the past 30 to 40 years of why there is that incompatibility. One of the main incompatibilities is that pigs have certain sugars in which we have natural antibodies against, meaning that our body reacts immediately once we connect the kidney. The second thing is that there are few physiological differences. When we separated from pigs more than 80 million years ago, there are differences in how our physiology or complement coagulation works that we had to learn what are those differences and how to overcome. And last of all, there's always this theoretical risk of an infection transmission. We've been through COVID, and we would hate to go through another major infection and pandemic overall. So these were like the challenges that we had to overcome. The real game changer of xenotransplantation, why suddenly we're talking about this to moving to humans, has been the CRISPR-Cas gene editing tool. So these are the magical scissors. This amazing discovery that led to the Nobel Prize into Dona and Charpentier in 2020 that allow us to precisely and accurately modify the gene, and not only one gene, multiple genes in a very efficient way. So suddenly, if you know what are the problems, what are those incompatibilities, we're able to change them. And then similar to what you may have heard in the past about cloning and building Dolly, the sheep, that's exactly what you do as a first step by doing those modifications. And these are the pigs that we use. These are mini swines, Yucatan pigs, in which their size goes up to 150, 180 pounds. There were some genes that were removed in order to improve that compatibility. There were some viruses that were inactivated in those pigs. And there were certain human genes that were added. And these human genes were added in order to improve the regulation of both coagulation and some of the inflammation that happens. So these pigs were produced with all the compatibility necessary for us to transplant them into humans. And finally, the infection risk, of course, was a concern for us, physicians, for the regulatory agencies. But one thing that has been done in order to minimize that risk is that these pigs are grown in a very isolated fashion. They're tested from birth. And they also undergo all these genetic inactivation of endogenous viruses that could cause infection. So overall, we feel that transplanting an organ from a pig, like the ones we're showing you here, is actually a lower risk than even getting a kidney from a deceased donor, just because of all the testing that happens throughout their lifetime. So in March 2024, we were able to do this transplant, but it was, a couple of years of work in order to get there. Similar to what you heard from our first panelists just before me, the FDA was essential for making this happen. So the work that we did with the FDA would not have happened, I think, in any other place in the world, because we felt that, we were true partners and collaborators on this. They wanted to ensure that there was safety in whatever we were trying to do. And we worked side by side for many months in order to get the protocol to the regulatory, all the strict rules that they want us to do to minimize any potential use. And the way we got this through was a little bit unique, so different than a regular drug where you may cherry pick the ideal patient that may work. On this case, we use a very specific regulatory pathway the FDA called compassionate use application. So we select a patient that has a life-threatening condition and no possible treatment in which you provide that treatment. It's not ideal, but in the case of xenotransplantation, it was essential for us to learn as much as we could as we design larger studies going forward. And in March 2024, we did the transplant. It took about 4 hours. We select a patient that had been on dialysis a total of close to 8 years. And unfortunately, he had a few more years still to wait because of his blood group. And he had a lot of cardiovascular disease. The surgery took about 4 hours. You can see on the left side of the image how the kidney kind of looks. So it's kind of pale once it's outside the body. But once you connect the kidney, it kind of pinks up. And that's what you see on the left side. And within the first day after the surgery, he made more than 3 liters of urine. So that's one of the first best signs that the kidney is working. Of course, if you ask me, how do I know if my kidneys are doing okay? The most important thing is a blood test called creatinine. So it measures a waste product that your body produces. So the waste product has to go down as the kidneys start working, and here you can nicely see that the creatinine went down from 10 to below 2. There are a few fluctuations on, but the creatinine and the kidney function was remarkable for those two months. And truly, the pioneer of all this was the patient, because he accepted to go through a protocol that was just completely unknown. We couldn't tell him what are the true risks of this because it was never being done. And he went home after 18 days off dialysis. He remained for 2 months off dialysis at home. And unfortunately, on day 52 after the surgery, he had a heart disease, an arrhythmia, and ended up passing. But the kidney never failed. So it's a step forward, but not the finish line. And this is the publication that had all the details that we were able to learn on this single case. But we didn't stop there, and this is what he had told us, and his family as well. And then we did our second xenotransplant, and this was after getting approval for the FDA to do 3 subsequent kidney transplants. But in this case, we have been able to select patients that were not as sick as the prior patient that was transplanted. And on January 25th, we completed this transplant. This time, he left the hospital after 7 days. And this is a picture just about a week ago that he was just coming for a regular visit in the clinic. And his kidney function is doing really well. And we hope that this is, just the beginning. There are 2 more coming still this year. So what I show you is that xenotransplantation has the potential to address organ shortage. We're able to show that this kidney can work, can function normally, can maintain some of the blood minerals in the blood as normal. And we haven't seen any evidence of infection transmission, which has been a concern. A long way to go, but definitely a major step forward. Thank you. I'm not sure if there's questions or... Do you need microphones? Or? No? Thank you.
I was wondering, so over time, people keep doing the xenotransplants and, they have, a child with someone else, would the children eventually have, hybrid adaptation?
So, because only the kidney is going to get transplanted, most likely there won't be any mix-up of DNA, but it's a good question in the sense that, there are a lot of potential things that your immune system may recognize as foreign. And one question would be if in the long term, there will be an immune response that may impact other things. And to tell you the truth, we don't know at this time. Thank you. All right. Thank you.
Here to discuss accelerating innovation, AI, and drug discovery, please welcome James Collins, Professor of Medical Engineering and Science at MIT and core faculty at the Wyss Institute, Avak Kavajan, General Partner at Flagship Pioneering, with the Atlantic's Ross Anderson.
Okay. Jim and Avak, I'm really, really happy to have you here. This morning I had a very depressing conversation about how all of these budget cuts from the Trump administration are affecting biomedical research. So I'm glad that we're ending on a much more positive note and you can tell us things to be hopeful about. That's not an order, but I want to start, we're going to talk about AI and drug discovery. And you both have worked in this field and we're going to get to your research. But first, I just want to know, as observers of your field, when did you take a look at the landscape, the research landscape, and realize, wow, AI could be a really powerful tool for drug discovery?
Well, I work at Flagship Pioneering, where we like to ideate really early on. And we let our imaginations run wild. And believe it or not, the first inspirations came from what we were seeing outside of the research field. So when we started to see pictures of faces that never existed being generated, or Go being solved by a computer, we started to draw analogies with what we do on a day-to-day basis. We thought, well, could we design proteins this way? Could we interpret the behaviors of cells with the complexity of information and all the degrees of freedom using AI? Through analogy, through that transference of what we were seeing. And that's what inspired us to actually start some companies early on in the field using the science melded with the technology.
Yeah, interesting question, Ross. So I think as many can appreciate, AI is not a new field. It's actually older than me. And I think for me, the first recognition that AI could be relevant probably goes back about 25 years ago. As data sets representing the expression states of multiple genes in cells were becoming available through what was then called microarray technology, that I saw a number of groups looking to see how they could use those data sets to reconstruct networks inside living cells, to begin to understand how those networks break down in disease and how they're impacted by drugs. And it was work that inspired us to get into the field to really think about how one could use machine learning to reconstruct these networks and better decode what drugs are doing inside living systems.
And at that time, did most people think that was sort of crazy to do that?
No, I don't think people thought it was crazy, but I think that at the time it was interesting interacting with a number of pharma groups. Computation was not, 25 years ago, a very big part of pharma. So many of the leading pharma groups had small computation groups that were largely brought in after the fact. They weren't there to help design the experiment. They really were primarily doing statistics. Could you look at the data, pull out something? Now it's dramatically changed. So I think it was viewed as something maybe odd, but not crazy.
Now, Jim, your lab has done some really incredible work with antibiotic resistance. And before I have you tell us, how you used models to do drug discovery in that space, can you just sort of give the audience kind of a brief overview of how naughty that problem is and how dangerous it is, the sort of having all these strains that are increasingly resistant to antibiotics?
Yeah, it is a problem, and it's a growing problem. The bacterial pathogens largely grow resistant in the face of increased use of antibiotics. And they often can grow resistant to a new antibiotic within a year or so of introduction. The resistance has been growing now decade upon decade. In the past, these nasty bugs were limited to hospitals. As I tell my students, the worst place to be when you're sick is a hospital. Get out as fast as you can, primarily because of these superbugs. Now, these superbugs are out in our communities. They're in our child care centers, they're in athletic fields, they're in conference centers on 33rd floors of beautiful buildings. And this situation is unfortunately coupled with the fact that biotech and pharma have been getting out of the business, that the economics of antibiotics really aren't very good. It costs more or less just as much to develop an antibiotic as it does a blood pressure drug or a cancer drug. But you take an antibiotic once or maybe over 3 to 5 days, it costs a few bucks, whereas a cancer drug, blood pressure drug, you can take for many months, years, if not for the rest of your life, you can charge a lot more money than a few bucks. So it's a really dire, problematic situation that unfortunately is only getting worse.
And so where does AI come in?
I think AI is a big part of the solution. So I do think AI gives us a leg up in the battle of our wits against the genes of these superbugs. And I think AI really enables us to particularly speed up the discovery and now the design process. So briefly, what we were able to do going back 5 years ago was basically take a very small training set of drugs or compounds, 2,500, so really small. We applied them to a bacterial pathogen, E. coli, looked to see which of them exhibited antibacterial activity as evidenced by growth inhibition, took the structure of each compound, and trained an AI model, so-called graph neural net, that could look at the chemical structure, the type you remember from your chemistry classes in high school or college, where you look at bond by bond, substructure by substructure, and it could associate with it being an antibiotic or not an antibiotic. We then could take this model and feed it thousands, millions, billions of molecules that could look at the structure, now calculate based on that structure what's the probability it could make for a new cool antibiotic based on what had been trained. And doing this, we actually uncovered a powerful new antibiotic called halicin that's effective against multi-drug resistant, extensively drug resistant, and pan-resistant bacterial pathogens, including things like C. diff and Acinetobacter baumannii. So I think AI has done two things. I think it's dramatically speeds up the discovery process, and I think it's also reignited the academic and biotech world to what could be done in the antibiotic space with this powerful new platform.
Avak, you're using AI that helps to target diseases at the cellular level, as I understand it. And I wonder, how is that challenge different than the one that Jim just described? And yeah, give us a kind of overview of that.
Well, it's kind of similar, but maybe a little bit more complex in that we're trying to understand the biology at the same time as we're trying to find the right molecule to impact that biology. And in fact, small disclaimer, we both work on this company together called Celerity. But we had this idea that cells are undergoing programs, if you will, biological programs. There's n-dimensional changes that are going on in a cell as it's transitioning from health to disease. We as humans often just latch on to one aspect of that and find a target. Everybody agrees that's the target, and then we design a silver bullet to go and hit that target. And we said, well, that sometimes works when the disease is simple or when the causes of the disease are very obvious. But what if, as in many cases, the cell is going awry through a plethora of changes that we as humans can't wrap our minds around? So that was the first part of the question, which is, isn't this a job for AI? A computer system agnostic to the various human labels on all of these genes and all of these pathways, and have it tell us, here are the things that we think, or I think, if I were to personalize it, are the drivers of this disease pathway, and that one would want to maybe reverse or stop to prevent the disease. So that was step one. The other step was, similarly to the antibiotic case, can we take a few examples of drugs that have worked on cells and understand the consequences of that on those cells and create a large database of the chemical structure and the associated changes in cells? And then have a computer say, well, thanks to that database, here are some suggestions. Here are some things that you should try to reverse the pathways, to reverse those transitions. And again, we were a little bit surprised. We were saying, is this enough data? Has anyone done this before? Some people were saying, this is not going to work. You don't have enough data. And to our surprise, it did work. And through that process, we've been able to impact, for example, blood disorders, where a cell is not making the right kind of hemoglobin. Can we switch the train tracks to a different kind of hemoglobin without knowing the target, and just finding small molecules suggested by the AI to actually switch those train tracks and change the trajectory of the cell? And with that, we have at Celerity a candidate to tackle sickle cell disease, which is going to enter the clinic hopefully this year.
That's wonderful. Is there, as you all have, so when you look at this field, this all sounds very exciting, right? And when you take an analogy to large language models, right, which are also quite dazzling what they're able to do, but also have these kind of known limitations, right, whether it's to do with context window or hallucinations, and there's been gradual progress against those limitations, but nonetheless, like some of them are pretty stubborn. Are there analogous kind of difficulties with the drug discovery models that you all are, that appear to be really stubborn?
For sure. We're going to see things that don't make sense, that maybe break the rules of biology or physics or chemistry. But the cool thing about science is there's a ground truth. In literature, there is no ground truth, other than grammar maybe. In referencing and citations, maybe there's a ground truth, but otherwise, you can invent text and it might sound a little bit incoherent or crazy. Someone has to error check that, and only a human really can. In the realm of biology, your data, your experiment is the error check. And that's what we like to do, is constantly generate data, have a generative algorithm, let's say, using AI, suggest the next steps, suggest solutions, but then we have the ultimate checker, which is yet another experiment to validate or invalidate that suggestion, and then an updating of the model to say, that was wrong, this was wrong, try again. And through that, we get that kind of reinforcement loop of improving the algorithm. So it's a little bit like what people call fine-tuning or human-assisted fine-tuning, and which is a bunch of people telling the computer it's wrong. Well, we've got experiments and science and data that can help prove the algorithm wrong and fine-tune it to make it better. But yeah, we suffer from the same types of things.
Yeah, it's interesting, to pick up on Avak's points, a few things. One, there's nothing magical about these AI systems. They may appear magical to some of us on common use, but there's nothing magical. They were trained on a set of data with a certain underlying algorithmic structure and get you one. And related to that, these models are only good as the data that are put into them. And you look at the language models, they were trained largely on effectively the interweb, what's out there in terms of text. And there's value and there's not value. So, there's a lot of false information out on the interweb leading to the so-called hallucinations, and that these language models were not trained, in most cases, to be information providers. They were trained to generate text, which are two different tasks. In our world, it's training the models to think about particular tasks, whether can you predict the activity of this molecule, can you predict the appropriate target, again, limited by data. I think as we expand the data, we can move fast. I'll give you one interesting limitation we have in my world, which is I think these models are getting better and better at now predicting interesting new molecules that you could consider. The challenge we have is when you run up against the reality of can you make that molecule? Can you synthesize it? And that we haven't gotten very good models to predict synthesizability. In our antibiotic space, for example, we've moved now from using AI for discovery to using AI for generation, designing new molecules. We came up with thousands of interesting new antibiotic candidates, and in the end, we could only synthesize 6 after shopping around to 10 different groups, 5 of which were new antibiotics. But now you have those thousands of others, let alone many millions when you looked at the larger space. And so there are these gaps between what the computer can do and what we as humans in the lab still can do.
Is there a chance that the synthesizing tech will actually catch up to that, or are those hard limits? Like you'll never be able to make those?
Well, I think you can have the algorithm start to learn what is synthesizable and what is not, and no longer suggest bad ideas that aren't synthesizable.
I think that's a good point. Yeah, I think there are there are going to be chemical limits. There are chemical laws. There are physical laws that you're not going to get around. Sure. And so there will be limits as to what could you synthesize. There are also limits to what can you synthesize in a reasonable period of time for a reasonable amount of money. In an area that Avak and I overlap in, though not collaborate in, is in the easier space, I'll put in then small molecules, which is around proteins and nucleic acids, RNA and DNA, where now you're not significantly limited by synthesis, but you are limited by have you done your proper prediction on structure and even more so function.
Yeah.
You two are building these models or working at these companies or with these companies that are building these models for good, right? To find cures of diseases, effective treatments. Are there analogous models that people could build to generate quite dangerous proteins or compounds?
I'll take this first.
Yeah.
Yes. And we really didn't appreciate it. So, every tech can be dual tech. The bad actors can use it for bad uses, and it's unfortunate, but it's there. In our space, I think in the great majority of cases, you have the good actors trying to help humanity. But interestingly, about a year ago, we published a piece on explainable AI for antibiotics in Nature. And in that piece, we presented for the first time data where we also screened human cells for predicting toxicity. We looked at 3 different human cell lines, applied 40,000 compounds, trained 3 different models, and used it to identify compounds that would be non-toxic to human cells. After we published this, the guys in the black suits showed up to say, hey, did you think about that the bad guys could use this for the flip application, which is identifying toxic molecules that could be harmful to humans? And it's a real risk, particularly if they identify toxic compounds for which we don't have antidotes. Now, we similarly have efforts supported by the Department of Defense where we're using AI to try to come up with these antidotes for a broad range of toxins, but it's a possibility that is very, very difficult to regulate and control.
And as I mentioned earlier, to get the drugs, to get the medicines, to get to success, we're doing a lot of experimentation, we're spending a lot of money. So it's not like we're at the point where you can just ask a computer to give you a fill-in-the-blank terrible thing, and you will have it, and you can just go and make it, and you're off to the races. Sure. There is a lot of work still to be done. Now, we might get to that point where it gets easier and easier and easier, and it's a single shot answer that actually works. So we may get there eventually.
Jim, you mentioned explainability, and again, just to bring back large language models, an example that everyone understands. Anthropic, OpenAI have kind of consistently said that Anthropic's done some really interesting recent work on this, where they are getting better at looking under the hood of these LLMs to see how they're working, how they generate like individual particular answers. How does the explainability compare when it comes to drug discovery? Like, do you know to a pretty high degree of fidelity what the model's actually doing when it spits out one of these magical answers?
It depends on the models. I think that it's still early days for the application of these newer tools in medicine and biology. Exciting, but early days. And I think the two limits for uptake were the lack of data sets, and the second was the lack of explainability. That many of our colleagues don't like the black nature of many AI models, black box nature, where you give it an input, you get an output, might be a meaningful prediction, but they want to understand mechanism and what guided it. Efforts by our lab and other groups are advancing beyond that to get after explainability. So in the paper that I referenced, we got after a very simple insight was, could we see what was learned by the model from a chemical structure standpoint that led it to predict a compound to make for a good antibiotic or a good non-toxic compound. And the model was able, through various schemes, to give us insight into what were the substructures. And we now are extending this in many different ways. And I think it gives folks comfort to better understand what led to the prediction. That also helps guide then further development of that compound as it moves down the clinical
And it teaches us something about biology, or it teaches us something about the target. So there's a motivation for explainability. We're not always just interested in the answer. We're interested in understanding how it works, because it helps us make the drug better, and it opens up an understanding of that particular mechanism that can then be exploited for other things. So there's an inherent, in science at least, I think, a deep motivation to get to that explainability, because it has more value for us and it becomes actionable. And so we have orthogonal tools to get at that explainability. So again, the experimentation and coming at it from a different perspective. So for example, in one of our companies, a couple of our companies, we're doing generative protein design. So yes, you can just have it suggest the sequence, make it, show that it binds, and you can move on. Or you can try to understand what the structure is, you can understand what the contacts are, and then say to yourself, how do I improve this, and why did it make these decisions, and how do I make it better for that drug, but then also for the next one, and the next one, and the next one, because we're also trying to build platforms that are generalizable and reusable. So explainability for us, if that's what you define it as, is really important.
Have your scientists had those moments where, I remember getting goosebumps reading about AlphaGo in those early years, where they would watch the computer do a move and be like, wow, I never would have thought of that, but actually it's ingenious. Have you had those kinds of moments?
Oh, all the time. I think the celerity example is a really good one. The molecule it picked, you would have never, ever thought it would cure sickle cell disease. So the scientists were bewildered. I don't know why it picked this. It's working, and it's working over and over again. So let's go into the explainability to say, why did it pick this? How did we end up here? And then everything starts to make sense. Or a new area of science emerges that we had never thought about. So that was for us a goosebump moment. But it happens all the time as a result.
Yeah, I haven't gotten goosebumps, but
maybe you're not a goosebumps guy.
Yeah, I'm not really emotionally walled off Irish guy. But I've been impressed with the utility of these models, and to Avak's point, impressed with some of the predictions that these models are making, wondering how did it do that based on what we showed it. And the explainability is kind of giving us some insight, but not fully there yet. It is intriguing to see the ability of these models to see patterns and extract patterns that we haven't yet been able to extract or see.
The other thing, though, is without AI, some of these things we just would never have been able to do. So, for example, at a company called A Biologics, we're making proteins with completely non-natural building blocks. In order to do that, you have to synthesize. You can no longer rely on natural systems to make these things, so you have to make them chemically. But a lot of our discovery tools for antibodies, for enzymes, and other are built on panning, making millions of these things in biological systems, and then seeing which one works, seeing what sticks. But if you use non-natural building blocks, you can no longer rely on those systems. So this whole class of new therapeutic with non-natural building blocks was unavailable to us until we had computational design to give us ideas for what to put together and what to string together. So forget the eureka moment, just even getting started was not possible in this arena without computational design, generative AI to do this kind of thing.
Staying on that for a second on protein design, and I want to, after this question, I want to give the audience a chance to ask. I don't want to monopolize these guys' time, but sticking with protein design, I feel like the public really became aware of AI and drug discovery in 2018 with the early Google DeepMind AlphaFold results, and just to calibrate for us, how fast and how far have we moved since that moment? Like where should we think of ourselves as relative to 2018 now when it comes to AI and drug discovery?
Well, on the protein design front, we've accelerated in leaps and bounds. In fact, there are, I don't know, countless startups and companies using generative AI to do their protein design work now. It's almost become part and parcel of how antibodies are designed or enzymes are designed. So much so that it happened so quickly and it permeated everybody's work so quickly, I almost think we forgot about it in some cases. But it's shortening the cycle times, it's improving the probabilities of success, it's giving us designs we wouldn't have found otherwise. And so to me, it's almost now becoming routine, where you can generate a binder to a target very, very quickly. There are limitations in terms of the kinds of things you can do, of course, or if you don't have a structure of the target, you can't design anything to it with generative algorithms right now. But it is here, it is now. And a company called Generate that we've launched a few years ago is doing it to create antibody drugs, which are in the clinic. The other company, A Biologics, which I described using non-standard building blocks, is using it. And so we're now at that phase where we're playing it forward. AlphaFold was predicting the structure of a protein from its sequence. We're now at a point where we can have it suggest a structure and derive the sequence that's necessary to make that drug. So it's almost been flipped in reverse in a generative way. AlphaFold was not generative per se, and now we're moved into the generative realm.
And would you say that for the average patient, the first place that they're going to encounter sickle cells, I guess a rare disease, but would it be antibiotics? Where are people going to encounter AI-discovered drugs for the first time?
I don't know. I think it'll depend upon investment to advance molecules to the clinic. So the company that Avak and I are involved with, Celerity, has a molecule that is promising, that for sickle cell that's advancing, that may be one of the first to be approved. So I think one or two have already moved towards clinic. The antibiotic that we discovered, Hallicin, is moving towards the clinic through a nonprofit we have, FairBio. But I suspect it probably would be the protein space over the small molecule that may see it faster for various efforts around generative design and the massive investment that's gone into that in the last 2 years.
Questions for these guys?
Can AI hinder critical thinking skills? Well, I do think it might make us lazy in some respects. If it took a lot of reading papers and devising chemical structures and then doing long, lengthy experimental campaigns, interpreting those data late at night, if it maybe shortcuts some of those things, it does maybe make you lazier, but it, I think, frees your mind up to do the higher order thinking and or to conduct more thought experiments and more experiments. So in some ways, it's like the calculator, it's like using spreadsheets, it's things that you maybe don't want to do anymore, and now you start doing other more creative things thanks to the power this gives you, this superhuman, super intelligence that you can now leverage to do some other things and or do more things at once.
Yeah, excellent question, and it's one that I think about a lot. I have 2 kids, both grad students, and I think that the smartphones and the AI type technology that's being introduced is harming our young generation. More so than calculators. I appreciate calculators. Do you still need to know how to do basic arithmetic? I think yes, to understand it, and you won't always have a calculator. But I think one of the problems is that I see is young folks don't read the literature at the level that they should to become an expert. I think young folks want to be influencers more than experts. I really value experts, and I think to become an expert in whatever field you choose, you really want to master the field, master the body of knowledge, the skills. And the machines give you the excuse you don't need to do it. You can always look something up. But I think the really creative people, the ones that somehow are making connections between the bodies of knowledge that you've committed a lot of time to store in your head and make those connections, whether you're out for a walk or a shower or on a treadmill. And the machine will probably soon be able to do that. There's a company that a Vox team is creating. But I think I would still bet on the humans for the next few decades. So I would say that to make that commitment to storing and using the machine as a thought partner versus in place of your brain.
I heard a little goosebump stuff in there. That's, there's, any other?
This might be unfair to ask, but trying to get a sense for how fast this will lead to success. Any ideas, for example, when we might double the success rate of clinical trials, or where we might have the failure rate? Like how far away are we from that kind of a thing?
I don't think we're that far. We had this discussion before we did the panel. I think it's a little unfair to judge it based on clinical trial success. There's going to be a lot of probably discussion about the first few drugs that go into the clinic that may not work, and then they're going to say, aha, see, AI is no panacea. I think that's going to be a red herring in the negative sense. AI is only one piece of the drug discovery continuum and development continuum. There are 1,000 things that can go wrong in the development of a drug that have nothing to do with the AI's prediction, have nothing to do with the AI's clinical trial design. Who knows where the failures are. So I think over time you're going to see the bottlenecks in drug discovery shrink and or the methodologies change in such a way that we are going to see that in the next 5 years. I think it's already happening, it's just invisible. And I'm bullish on it, that for the sickle cell drug, not to go back to that, or some of the new proteins we're making, we would not have discovered them as quickly and as easily as we did. And so instead of taking 7 years, 10 years, it took us 3 years. But nobody knows that. And then will it succeed in the clinic or not? Who knows? But it won't be because of the AI. It would be because of something else, which can happen in this difficult field, right? So I think it's already happening, but the proof will play out, and we'll be able to look at it retrospectively in 5, 10 years to say, did that inflection happen as a result of AI?
I think AI is largely right now having an impact in the early discovery and next aspect of discovery in the drug development, and has not had the impact yet on the further downstream, largely because lack of data. And I think it's when we get to there that you'll see these big jumps. And I don't know how far out that is, but I remain surprised at the limited data of moving from, say, your hit to your lead to optimizing it, moving it to a clinical trial with increasing success both for efficacy and safety, minimizing tox.
But that said, on the clinical trial design side, there's already a time compression going on. So we have one company that's taking an AI algorithm to look for individuals who might have a disease to recruit for a clinical trial. And it can roughly cut it down by 10x in terms of identifying people. Instead of just taking all comers and then having them interviewed and go through diagnostics to say they're eligible or not, the AI is already predicting it, and the enrichment is 7-10-fold already. So I think every step of the drug discovery process is getting transformed.
Jim Avak, thanks for being with us this afternoon, taking us out on a high note. Appreciate it.
Thank you.
Thank you all for joining us. We hope today's program was a valuable experience for you. Please take a moment to share your thoughts with us by completing our post-event survey. Your input is very important in helping us shape future programming here at AtlanticLIVE. Thanks again to all of our speakers and to our underwriter, Eli Lilly and Company, for their support of the Atlantic's Journalism Today. For more information or to join us for upcoming events, head to theatlantic.com/live. Thank you all for joining us today.